This is another joke. Listen, Okay, good morning, everyone. Morning.
Good morning, sir.
Hello, good morning.
Good morning, sir.
Can you hear me?
Yes, Prof, we can hear you. Good morning, sir. Hello, Prof. We can't hear you again. Hello?
Hello, good morning.
Good morning.
Good morning, Prof.
Okay, thank you very much. Let me share the screen. Okay, am I sharing the screen? Okay, let me I can start. Okay. The topic of today's discussion uh, is, or the first lecture is on spasticity in the pediatric population. By way of introduction, we define spasticity, or spasticity is defined as velocity-dependent resistance to passive stretch or elongation of particular muscle when the patient or the client attempt full relaxation. In essence, spasticity, because there are other hypertonic condition of the muscles in children, there is what we call rigidity, there is what we call spasticity, and there is what we call dystonia. There are so many conditions, hypertonic conditions of the muscles of the child. Therefore, for spasticity is usually unidirectional. What we mean by unidirectional is that if the spastic muscle are the flexors, then the limb is going to be either flexed, or if the spastic muscles are in extension, the limb is going to assume extension. Therefore, if the spastic muscle are the flexors, if the limb assume flexion, then extension will be difficult, while flexion would be free. Therefore, it's unidirectional. It's usually moving against the direction of spasticity is what we use to test spasticity. But moving in the direction of spasticity is usually seamless and free. Therefore, we call it velocity dependent. Again, being that the faster the movement, the more somebody who is testing the muscle for spasticity feel catch or resistance. Therefore, in definition of spasticity, we say velocity-dependent increase in start passive elongation or stretch of the muscle when a patient or the client assume full relaxation. When the individual is fully relaxed, is not attempting to make any contraction of the muscle. Therefore, the resistance we feel is as a result of spasticity, not because of the contraction of the muscle of the patient, and is usually unidirectional. But when it is rigidity, which differentiates spasticity from it, is that there is the resistance is bidirectional, in the sense that where there is rigidity, most especially in people, in individuals with Parkinson's disease and the rest, moving the limb into flexion and extension will encounter resistance. But if it is in spasticity, movement only in one direction gives resistance, but in the opposite direction, it may likely to be free. Then alternatively, spasticity has been defined as inappropriate involuntary muscle activity associated with upper motor neuron paralysis. Therefore, and as we said, yes, it's as a result of this inhibition of gamma motor neurons that are usually inhibited by the cerebral cortex. After an injury occurs, the inhibition that is brought about by the cerebral cortex will now be relieved, and the gamma motor neuron that control the muscle spindles in the muscles will now fire under control, not under full control of the central nervous system, and that brings about spasticity. Then the next is the causes of spasticity. The major cause of spasticity is upper motor neuron lesion. Therefore, the upper motor neuron lesion can be in conditions like stroke. It can be as a result of head injury. It can be because of static lesions in the brain that are non-progressive, like cerebral palsy. It can emanate from spinal cord injury, most especially high-level spinal cord injury. When we say upper motor, we mean, the central nervous system is composed of the brain and the spinal cord. Therefore, anything that is above cauda equina is upper motor and is likely going to present with spasticity. Then we have some hereditary conditions of children, like hereditary spastic diplegia or spastic paraplegia. All these guys present with spasticity. Then we have some progressive neurological disorders, like Parkinson's disease, amyotrophic lateral sclerosis, multiple sclerosis. All these guys can present with what do you call it? Spasticity. Some of them may present with both spasticity and rigidity, like most especially the Parkinson's disease. Then the consequences of having spasticity in children with neurological disorders. When a child has spasticity, most especially the ones we used to manage almost all the time in the clinics, most especially cerebral palsy, those with head injury, they said it aggravates motor disability. What they mean here is that spasticity impedes normal muscle action. Therefore, relaxation of muscle and contraction is going to be affected. At times, severe spasticity hold the limb in an abnormal posture, and at times, it refuses the muscle to grow. One of the reasons why we used to have shortened, what do you call it, contractions in a particular direction, either in flexion or in extension, most especially in flexion, the muscles in the direction of spasticity, because of lack of stimulation of movement. That is why passive movement is very important. They don't just contract, they also don't grow. Therefore, they tend to become shortened as a result of lack of growth. Then we have leads to abnormal posture. We know all these things. It leads to joint contractures, meaning that all the tissues around the joint, the tendons, the ligaments will become contracted. Even if the joint is normal, but the tissues around the joint are contracted, and that will lead to abnormal posture, either in the limb or in the spine, anything. That means also abnormal range of motion, reduced range of motion. Impaired standing and walking due to chronic seizuring. Therefore, we can see we have been discussing the issue of gait. When you have chronic seizuring, at times children would walk on their toes, at times on the side of the leg, at times the legs are going to cross over each other. Like in the seizures gait, it's meaning that it affects the gait of the patient. It's loss of voluntary movement due to flexor or extensor spasticity. We have said this point is related to the first point. Slowing of voluntary movement. You know, we used to say spastic muscles are weak muscles. It is just because when we move the spastic muscle, we feel the resistance. We feel that the muscles are strong. Actually, it's spasticity that is causing the resistance, but the muscles themselves are very weak. Therefore, it's what do you call it? It impedes the weak muscles from acting to their maximum capacity. Therefore, it slows down the voluntary movement of the patient. Then it affects proper positioning, difficulty in sitting and transfers. Yes, at times even backing the baby by the mother, she wants to back the baby, but she cannot because the baby's hip and knee joints are contracted. At times sitting the baby, even if it is with CP chair, may be difficult. At times standing the baby may be difficult. Therefore, positioning of the baby tends to become difficult, most especially in cases where the spasticity has leads to what do you call it, abnormal posture, or it has resulted in abnormal range of motion in either peripheral or the axial joints. It increases the risk of contracture and joint subluxation. Yes, it's very common to see contractures. We have been saying that one. And then what about subluxation? Usually, subluxation in spastic muscle don't occur just like that. Unlike in children with Down syndrome that are used to having subluxation. But if a physiotherapist is not mindful of the amount of force he applies to a muscle during passive mobilization, most especially when the muscle is giving serious resistance, you are likely going to get the joint of the child being subluxed. But it's a rare thing to see subluxation just like that in a child with neurological affectation. But remember, children with cerebral palsy are used to having hip dislocation. That one does not have to with spasticity. Then it causes difficulty with hygiene and dressing. Yes, packing the baby is going to be difficult. Sitting the baby is going to be difficult. Standing the baby is going to be difficult. So also the issue of bathing the baby. when the joints in the limbs are contracted and across the what do you call it, the body, in like in the upper limb, when the two legs are contracted in scissoring form, therefore even what do you call it, birthing the baby is going to be a bit difficult for the woman or for the mother or for the parents. At times, even putting the baby in a correct position such that the baby will relax during bathing is going to be difficult. Then the next is pressure sore. Yes. If the child is left at home and nobody cares about the child too much or left in a particular position to sit from morning till evening without the proper changing of position, the child is likely going to develop pressure sore. Then persisting causes pain, and that is one most important aspect of what do you call it, care for spasticity, because definitely spasticity causes pain. Uh, Most of us that are used to managing children with severe, what do you call it, spasticity, we know that some of these children used to cry. Even those with severe cognitive impairment, from the way the children move, it shows that they are under intense pain when we perform passive mobilization. Even with the initial massage, even with the initial passive movement, even with the initial what do you call it, gentle stretching, at times they feel a lot of pain. Therefore, spasticity causes pain. Then inhibit muscle growth. I have said that muscles in the contracted area in the direction of spasticity, if one is not actually having the privilege to have physiotherapists managing him very well, the contracted, what do you call it, muscles in the direction of spasticity are not going to grow. They are going to become contracted. Then we said spasticity marks muscle weakness. Yes, we said spastic muscles are weak muscles. Therefore, any medication that reduces spasticity, any form of injection, either botulinum toxin injection, phenol injection, that reduces spasticity will now make the limb, will now expose the weakness of the limb. That is why most of the, what do you call it, the newer techniques of managing spasticity, they don't achieve their aim without doing intensive physiotherapy post-injection. Therefore, when the injection is administered, then there used to be, or physiotherapy interventions like strengthening exercise, intensive exercise has to follow, because spastic muscles are weak muscles. It is only the resistance that we feel when we move the child that we thought the muscles are strong, but actually they are weak muscles. When the spasticity is gone, then the weakness in the limb is going to become very apparent. Then it's not bad. They said uh, spasticity also has some positive aspects of it. The first one, they said extensor tone in the limbs of the child with hemiplegia helps with standing. Therefore, this is also common with stroke patients because of the extensor tone. We call it extensor synergy in the lower extremity. Therefore, even stroke patients, spastic patients that have our extensor spasticity in the limb, they tend to bear weight. We begin to feel as if the patient is doing well, but not knowing that it's the spasticity that helps the muscles, what do you call it, to have to apparently show as if there is strength, but actually they are weak muscles. The next is it preserves muscle bulk. Remember, spasticity has also been defined as inherent or increase in electrical activity in the muscle. Yes, it has also been defined as increase in electrical activity in the muscle, involuntary increase in electrical activity of the muscle. And then tone itself, not spasticity, is defined by the resting electrical activity in the muscle, meaning that the muscles are not just like that. There is an resting electrical activity in the muscle. Therefore, when as a result of injury, most especially for referral nerve injury, when this electrical activity is gone, then the muscle will become what? Hypotonic. Then, under normal circumstances, the muscles have some tone. Then, as a result of upper motor neuron lesion cerebral palsy or head injury in the child, there is likely going to be heightened electrical activity in the muscle. And that heightened electrical activity in the muscle helps to prevent severe muscle wasting. Therefore, even if there will be muscle wasting in a child with upper motor neuron lesion, it's going to be mild compared to when it is lower motor neuron lesion. Therefore, spasticity in the muscle, because of the heightened increase in electrical activity in the muscle, it tends not to allow for rapid atrophy of the muscle. Then it also preserves bone density. Therefore, you would also testify that it's not very common for physiotherapists moving the limb or mobilizing the joints of a child with CP to just find that the hand breaks or the leg breaks, because the bone density in those muscles tends to be preserved because of the inherent activity in the muscles. Therefore, there is little movement, no matter what. It's not like in a flaccid muscle where there is no movement at all. These guys used to have some little movement and inherent activity that tend to preserve some of these bone densities. The next thing is the outcome measures. The outcome measure, actually up till today, the outcome measures for assessment of spasticity in both adults and children are the same. We don't have any separate instrument. We use modified Ashworth scale to assess spasticity in children, just like in the neurological adult patient, and we have modified Tardieu scale. And modified Ashworth scale, some researchers have argued that what it measures is just muscle tone, not spasticity. And their argument is spasticity is defined as velocity-dependent increase in muscle tone. Therefore, in the assessment of spasticity using modified Ashworth scale, there is no that instruction that somebody should move a limb fast or somebody should move a limb in 3 different velocities. First velocity to ascertain where the catch come from, second velocity at faster rate than the first movement, and then the third velocity. Therefore, there is no such instruction in modified Ashworth scale. Therefore, they felt that what we are assessing is more or less of muscle tone, not spasticity. But actually, up till tomorrow, it has been validated that modified Ashworth scale is used for measuring and it's an objective measure of spasticity. The scale is an ordinal scale with scoring ranging from 0 to 4. But actually, there are 5 ordinal levels: 0, then we have 1, then we have scoring of 1 plus, 2, 3, and 4. Then for research purpose, because we don't have 1 plus in most of the analysis we did, we have 0 to 5, 0, 1, 2, 3, 4, 5 is still acceptable. Then we have the modified Tardieu scale. The modified Tardieu scale come as a result of the inherent complaints due to the nature of the scoring of modified Ashworth scale. They felt that, okay, they should come up with another scale that measures spasticity based on 3 different velocities, velocity 1, 2, and 3. That is the difference. And then you use similar scoring like that of the modified Ashworth scale to now score. That's essentially what modified Tardieu scale is all about. Therefore, we use them to measure spasticity in children with neurological disorders. Then we now come to management of spasticity. The management of spasticity is actually multidisciplinary. It's multidisciplinary. It requires the services of the therapist. It may require the services of an occupational therapist. It may require the services of a surgeon. It may require the services of a physician. Therefore, all these professionals can be involved in the management of spasticity. Therefore, we start with therapy. We have oral medications like diazepam and the rest. We have botulinum injection. We have phenol, neurolysis. We have selective dosal rhizotomy. We have intrathecal baclofen, and at times tendon transfer surgeries in orthopedic surgery. All these ones can be used to manage a patient with spasticity. Okay, the first approach, we have the physiotherapy modalities. The modalities that we use in managing spasticity, the first one is we have the massage therapy. Massage therapy and stretching may prevent contractures and promote muscle growth. But let's discuss this. The issue of massage and stretching. Actually, there are so many studies that shows that they might not be effective in a child that has already developed severe contractures and spasticity. Therefore, it's better for a child that does not see what you call it, it's better we use them as prevention. Therefore, whenever the doctor refer a patient to us, that okay, this is a child for for physiotherapy management, that is when our massage, our passive stretching is going to benefit the patient the more. Therefore, we do as much as we could to prevent contractures and prevent spasticity, severe spasticity from setting in. The therapeutic positioning we are seeing is very important here. It will also help to elongate the muscles. It will also, ensure that severe spasticity did not set in. Then a systematic review has reported that massage administered as an adjunct to traditional therapies should be used to reduce tone in spastic type CP. Therefore, what this systematic review is saying is that you cannot use massage alone for management of spasticity. Therefore, if there are other techniques for managing the child, then you can use massage as an adjunct. Are you using orthotic device for sustained stretching? Yes, before you put the limb in the orthotic device, you can do a lot of massage, a lot of stretching before you put it. It can be used as adjunct to other therapies, but it can never be used as a lone therapy. For managing a spasticity that has been established or a contracture that has been established, it will not work. But you can use it as a form of prevention, or you can use it as an adjunct to other therapies for management of what? Spasticity. That is it. Then the next is use of orthotic devices and serial casting. Orthoses are designed to provide joint stability, to hold the joint in a functional position and to keep tight muscle stretch. You know, there is something we used to do in the clinic. We used to say we do sustained passive stretching. I stretch and I hold for 5 minutes. After that one, I release. That one will never cure our, help in the management of spasticity. But if I use an orthotic device that the child is going to sleep with for 24 hours or for 12 hours, or will use it almost 18 hours of the day working with it, it produces the needed stretch compared to when I use 2 or 3 minutes of stretching. Orthotic devices provide prolonged stretch, offers biomechanical benefits, and inhibit spasticity. What they are saying is two factors come into play here when one is using an orthotic device to stretch. The first thing is it provides biomechanical benefits in the sense that it will stretch the limb to the extent, or to stretch the muscle to the limits that the therapist wants. The second thing is it is also going to be a type of treatment that will protect the joints of the patient. Therefore, the joints are also protected in the particular orthotic device. The third one is it inhibits spasticity. Therefore, when I'm using my hand, there is tendency, if I do not use the correct technique, I'm going to hurt the joints of the patient. Therefore, orthotic device, if somebody uses them appropriately, the joint of the patient is going to be protected. The muscle is going to be elongated to the desired length, and finally, the spasticity will be inhibited. Then the issue of serial casting to lengthen the serial casting to lengthen already shortened muscle and soft tissues, and to prevent or correct contractures has been employed for some time with good clinical outcome. What they are saying is, if you use orthotic device or you use serial casting, you're likely going to get the same thing. But the most important thing is, they said, using it to lengthen the already shortened muscle or to inhibit the spasticity has been shown to have what? good clinical outcomes. Meaning that if somebody comes with a contracted, most especially knee joint, elbow joint, most especially peripheral joints, yes, most especially peripheral joints, they are good candidates for serial casting, and it involves applying the serial cast in a particular range. Probably you want to achieve the elbow, you want to achieve full extension, therefore from flexion. Therefore, you move it to a particular range, you do serial casting, and you leave. After some time, let's say 1 week or so, you now break the cast, then extend it more, and then you now what do you call it, stabilize it until the limb achieve full extension. Meaning that you can use serial casting to inhibit spasticity. You can also use serial casting to gain range of motion in a muscle that in a joint that has been contracted. Then they said precaution to serial cast application. They said longer term of serial cast application, 6 weeks or more, cause weakness of the antagonist muscles. What they are saying here is, remember, okay, am I sharing? Okay, sorry about the network. We are discussing the issue of longer term of serial casting. Remember, I was saying something about, I gave example of our biceps. If the biceps is contracted, what happens is the elbow joint is going to be flexed. Therefore, in applying serial casting to stretch it, remember the definition of spasticity is unidirectional. Therefore, it follows the direction of the spastic muscle. Therefore, in this case, the spastic muscle is biceps. If I am stretching only biceps, not triceps. Therefore, the extension of the elbow joint is working against the biceps that is contracting into flexion. Therefore, if I apply these things 6 weeks or more, yes, I'm going to achieve something in biceps, but the triceps are going to become weak because of what? Disuse. Therefore, they are going to become weak, and that is the reason why it is advisable that one applies it and remove it weekly. Therefore, you apply it, remove it weekly, do some passive exercises, encourage passive exercise for some time, then you apply it again. The casts are often now applied for shorter period, change more frequently, such as every 5 to 7 days. Like after 7 days, we do some exercise to the antagonic muscles for some 1 2 days, then we reapply it again instead of taking it for a month. Therefore, we achieve something in the spastic muscles that are contracting the joint, but the other antagonistic muscles that helps to stabilize the joint are going to become weak. Then the outcome of some systematic reviews. What the systematic review says about this form of treatment, they said casting has insufficient high quality evidence regarding long-term effects on upper limb spasticity. Therefore, remember we said casting can be used to achieve two things. It can inhibit spasticity. It can also help us to gain appreciable range of motion in a contracted joint. Therefore, the first research that was a systematic review that was conducted by Lenin in 2007, they says there is insufficient high quality evidence, meaning that there are some, what do you call it? Some, when we say there is insufficient evidence, meaning that there are some researches that reported positive outcomes. There are some researches that reported negative outcomes, or the few researchers that reported positive outcomes may likely have some methodological issues. Then the researchers will now conclude that there is insufficient evidence. Okay. The second one is by Kerr et al. 2020. It's a recent study, just 5 years. They say static and dynamic splint for reduces upper extremities are now have low strength of evidence, meaning that if you are using a splint, therefore just a splint, cock-up splint, then or anyone that has a joint, they said it may not, based on, they said they have low level of evidence. Low level of evidence for now, based on the research by what do you call it, Kerr et al. But Kerr et al. Also said the strong strength of evidence was found for those using what? Stretching devices. Therefore, if you use any device that stretch the muscle for 1 week or so, most especially serial casting, most especially an orthotic device that is rigid orthotic device, they will help in reducing spasticity. But they said there is strength of evidence in these guys. Rigid orthotic devices will do that. Therefore, when you use a flexible orthotic device, it's likely not going to have effect on the spasticity. But when you reach a rigid orthotic device, it's likely going to have a strong effect on the spasticity. Then strengthening exercise. Actually, strengthening exercise on its own is not being used for the management of spasticity. No. But actually, because of the advent of phenol injection, botulinum toxin injection, what do you call it, selective dosal rhizotomy, all these new medical treatments, then this call for strengthening exercise as part of management of spasticity. Remember I said in the initial part of the lecture, spastic muscles are weak muscles. It is only when sufficient management of the spasticity has been administered, then you now realize that these muscles are weak. Then after either botulinum toxin, phenol injection, intrathecal baclofen, what do you call it, therapies have been conducted, then strengthening exercise will now become paramount, will now become very relevant. The targeted muscle strengthening exercises improve the strength of the weak muscle and has benefits specific in the clinical, has some benefits in clinical situations. What they are saying is, whenever, it's part of even the management, whenever a patient is to undergo selective dosal rhizotomy or what do you call it, botulinum toxin injection, immediately after that one, then the individual is going to undergo intensive physiotherapy in order to increase the strength of the weak muscles. Intensive strengthening is required post-bottle injection and phenol injection and following selective dosal rhizotomy. Then we have neuromuscular electrical stimulation. Please, this also can never be used as stand-alone treatment. It can also be used as adjunct to other treatments. We have a systematic review by Wu et al. 2023 is also very recent, found that electrical stimulation decreased spasticity in patients with cerebral palsy. Therefore, the modalities, remember what one thing with systematic review, they gather what do you call it, so many studies, most especially randomized clinical trials. They gather using a particular criteria, they come up with the level of evidence for using a particular modality. Therefore, when we mention them, one can go and read about them. Then what is the frequency they use? What is the intensity they use? Then how many times did they apply based on the commonality of what do you call it? The interventions in the systematic review. But they said it can decrease spasticity in patients with cerebral palsy. The next is TENS. Actually, when I was going through physiotherapy modalities, I saw TENS. I said, this is meant for management of pain. But I saw systematic reviews on TENS, more than 5 of them. More than 5 systematic reviews on TENS in the management of spasticity. I decided to bring only one here. They said a systematic review reported that there is level 1 and level 2 evidence for its short-term effectiveness in the management of spasticity in various neurological etiologies. Then, now, if we can discuss, please, if they said there is level 1 or level 2 evidence, the most important thing is there is some level of evidence that it can work. That is the most important thing. But they said, in what? Short term. Let me go back to massage. Massage has some short-term effects on spasticity because it induces relaxation in the muscles, and then one can continue his treatment. They said TENS also has some evidence that it induces what? It reduces spasticity, but short term. Then why TENS modality that is meant for pain relief, why does it improve spasticity? The answer is not far-fetched. The reason being that spasticity causes pain. When we are moving the patient's limb, part of the little resistance we feel probably is as a result of the contraction of this patient's muscles when the patient is feeling pain. When there is severe pain in the muscle and we are trying to move the limb, some of these patients that can talk will begin to cry. Therefore, when you apply TENS in the muscle, the pain that follows stretching is likely going to be relieved. And I think that is the reason why TENS has short-lived effect on spasticity. But not that it directly reduces spasticity, it reduces the excess pain the patient is feeling. Probably when the patient is feeling excess pain, he tends to what? Hold the limb. And we, the physiotherapists, will feel that, no, it is not just, at times, it is not just the resistance from the muscles, the spastic muscle. At times, the pain that the patient is feeling will make the patient also hold the limb. Therefore, we are moving against the contraction of the patient and also the resistance by the spastic muscles. Therefore, when pain is gone, it will just leave us with the contraction from what? The resistance from the spastic muscles. I think that is probably the reason why it works. They said they recommend that clinicians should consider using TENS as adjunct therapy to limb spasticity management. I also recommend. We are not in physiotherapy department. We are not in physiotherapy to make the patient feel pain. Therefore, if spasticity causes pain, most especially severe spasticity, then we can use other modalities to relieve pain, to induce relaxation in the muscle. That is what we talk about at times in adults, not in children, heating modalities, at least some massage, at least some TENS, so as to have some muscle relaxation before we stretch, and that will be more effective. The next thing is manual stretching. We have started discussing manual stretching. Me applying stretching. We call it, sustained passive stretching. Okay, they said it was suggested that 60-minute stretch is likely to produce maximum effect on spasticity. This implied that sustained passive stretching for up to 5 minutes, the ones we used to do in the clinic, delivered manually by physiotherapists, may not lead to significant reduction in spasticity. It's just to, to lengthen the muscle, but it will never have effect on spasticity. They said only orthotic devices that can deliver therapeutic stretching in a consistent fashion provided compliance is maintained for lengthier period of time. What they are saying here is, for us to have meaningful stretch of a particular contracted tendon or ligament, is better we use an orthotic device that will help to stretch. Let me give you an example. The common back slap that we see, if you have somebody who has contracted reduced range of motion in the knee joint. We used to apply back slaps, and then we apply we hold it in place using crepe bandages. If you can do that and sustain it for a day, it's better than using your hands, asking the patient to lie down in in prone. Then you stretch the hamstrings. Yes, you can apply that one for 10 minutes, 20 minutes, even if it is 60 minutes. It will not stretch compared to when one is using a back slab that will last for 3-4 hours. Then they say systematic reviews. According to Ed et al., 2008, the systematic review by Ed et al., they said available evidence on the effect of stretching on spasticity is overall inconclusive. Yes, remember what we said. If somebody used 5 minutes to stretch, he will definitely report that it does not work. Some have reported that you have to stretch for at least an hour. But actually, a longer stretching is required for some days. Then they said there was a high quality evidence that stretching did not have clinical important effect on joint mobility in people with and without neurological condition if performed for less than 7 months. This is, please, I got this thing even yesterday. This is a Cochrane systematic review. Cochrane Library systematic review. They say for you to have good, effect on spasticity, the stretching will be done for at least 7 months. Meaning that if I stretch using a particular for 2 weeks and allow the patient to rest, I should continue. I should keep doing it for what? 7 months. This is what these guys are saying. This is a Cochrane systematic review, meaning that we should do more. Stretching, sustained passive stretching for just 1-2 minutes may not serve. For 1 hour, still may not serve. One systematic review is telling us that we have to keep doing it, even if it is with orthotic device, that will keep stretching. They said it will never have the desired effect if we do it for less than 7 months. They said there was no evidence for manual stretching to address spasticity at all. Kerr et al. Says no evidence for me to just use my hand to manually stretch. I am just stretching the joint, but it will never have effect on what? Spasticity. Now, thermotherapy. They said heat is not usually applied in children with CP, fear of bone injury. But if one is very careful, he can take care of the tender skin very well. He can apply heating modality to relax spastic muscles before stretching. They said most heat and infrared decrease muscle tone, reduce muscle spasm, and decrease pain. Therefore, even if one did not reduce spasticity directly, it can reduce what? Muscle spasm and pain. And that will lead to, one's ability to be able to mobilize the joint and stretch, the contracted muscles. They said the effect of spasticity by thermotherapy is short-lived. Just like we call massage, we talk about TENS, we are talking about heat therapy. Therefore, the effect of these modalities on spasticity is usually what? Short-lived. When you have a child with spastic type of CP, head injury and this, and you want to mobilize, most especially just use a Boba technique. You want to teach sitting, standing, you can start with massage, you can start with little stretching, so as to be able to mobilize the patient very well. Then cryotherapy. This is not usually applied to children with CP, but one can still apply, but with caution for fear of frostbite, temporarily decrease spasticity and clones. It also what TENS does is the same thing with cryotherapy. It relieves pain. It also relieves a lot of spasm. Therefore, one can easily move the joint. Only that the spasticity is the spasticity reduction is short-lived. At times, even before you finish treatment, the spasticity must have what? Come back. Then they said Reduces spasticity mainly by reducing the sensitivity of late threshold afferents and muscle spindles to stretching. Therefore, what it does is relieves pain, it relieves sensitivity of what? Afferent muscle fibers and the muscle spindles that are under the control of gamma motor neuron. Then the new therapy that is not very, very common in our environment is part of the repertoire of the therapy treatment. Uh, is called extracorporeal shock wave therapy. I know the first one that we know before is the extracorporeal shock wave lithotripsy, the one that is used in disintegrating kidney stones. When somebody is diagnosed with kidney stones, they use extracorporeal shock wave lithotripsy. But using the same principle, extracorporeal shock wave therapy was produced. And initially, is our professionals from orthopedic and musculoskeletal physiotherapy that use extracorporeal short wave therapy in the management of musculoskeletal conditions, tendinitis, plantar fasciitis, all orthopedic conditions that has to do with tendons, facilitating healing of fractures. All these ones, they use it. Then they said, now gradually it has become an alternative treatment for spasticity in children with what? CP. The extracorporeal shockwave therapy has three mechanisms of generating shockwaves. They call it, we have the electrohydraulic, the electromagnetic, and piezoelectric. Therefore, those that are interested in shockwave therapy will go and read more and more about it. They said the shock waves are a sequence of single sonic pulses that started by high peak pressure. We have fast pressure pulse, and then we have short duration. But up till now is a newer technique. They say the mechanism through which it induces changes in tissue is still uncertain. There are some researches. Remember, it's shock wave, just like ultrasound, but it has other properties, electrohydraulic and electromagnetic. Then but it also produces some form of sound. Then this is what do you call it? The uh, extra corporeal shockwave therapy being applied to the heel of the shoe of the leg for management of tendinitis. Then what are the indications? Remember, we said initially shockwave is used for management of orthopedic related conditions, but it has been used for the management. It has been now been proposed for the management of what? Spasticity, focal spasticity of a particular limb, not whole body spasticity, focal spasticity. I'm interested in releasing spasticity in hamstrings or in quadriceps or in biceps or in those flexor muscles. Then I can use shockwave therapy. Okay. Then they say musculoskeletal indications, delayed fracture healing. If somebody is having delayed fracture healing, one can use it. Bone marrow edema, one can use it to relieve the edema. Osteonecrosis in the early stage, that is avascular necrosis, they said one can use it. Insertional tendinopathies, that's in the insertion of the tendon. Then plantar fasciitis, all these guys. Therefore, for somebody who is having this, it's like treating plantar fasciitis. Therefore, that is what they use it for. Then they said, now they propose to use it for abnormal muscle tone. And they have started using it, but in the management of focal spasticity. Then contraindications. For those of us, one day I know we are going to have it is handy. Some of them come as portable, but the initial, what do you call it, extracorporeal shock wave lithotripsy is like ultrasound machine with a screen, with a probe, with a gel and everything. One can easily locate where the kidney stone is, and then disintegrate it. But this one can be handy. Severe coagulopathy. Somebody is having a case of coagulopathy in order not to dislodge any uh, 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 not to dislodge, more especially in the veins, not for them to be dislodged to cause embolism. Then we have pregnancy. Yes, what they say, pregnancy is, they said up till now, the effect of lithotripsy on the pregnant uterus is still uncertain. Therefore, it's better one does not apply it on the pregnant uterus. The third one is severe infection. Therefore, when somebody is having severe infection, it may lead to the spread of what? The infection. And the other one is patient suffering from hemophilia because it may cause microvascular disruption. Therefore, if it causes bleeding, then there will be something. Okay, remember, I think I did not say something. Let me go back a little bit. Okay, here they said it's a non-invasive therapy used in the management of pathologies of musculoskeletal system. That is initially what it's meant for. They say it has few unwanted side effects. The first one is what? Temporarily skin redness. The second one is mild pain during treatment. What brings about this temporary redness is that microvascular impairment. Therefore, that redness may lead to the small, tiny blood vessels are likely going to break. Therefore, if somebody is having hemophilia, that may be, what do you call it, a cause of more bleeding for him. They said it's just tiny microvascular redness, but to be on the safe side, for individuals with hemophilia, it is not what? Encouraged. They said extracorporeal shockwave therapy should not be used in treatment of clavicle or first rib to avoid exposure of the lung tissue to the beam. Therefore, they said as much as one could should not expose the lungs to the beam. Okay. Then they said malignancy. Therefore, if somebody is having any cancer, or for children with growth plates, remember, like ultrasound, you don't apply it to the growth plates. Go, it's going to affect the growth plate, and the child is going to have retarded, what do you call it, bone growth. Therefore, up to now, they said the effect of malignancy and what do you call it, growth plates in children is not known. Then one should be very careful in applying shockwave in the growth plate zone. Then, what are the systematic reviews for now? We have the first systematic review was conducted in 2019. They said there is limited evidence for management of muscle spasticity in children with cerebral palsy using what? Shockwave therapy. Limited, meaning that since the researches are not many, probably one will have one or two research that said no, but as more and more researches are being conducted, it will be clearer whether it's going to be effective or not. Two, the study by Kim et al. Could not draw any definitive conclusion on the effectiveness of what? Extracorporeal shortwave therapy or reducing spasticity in children, meaning there is still more researches are needed. The third study is done in 2021. They said by Kudva, they said studies are needed to establish optimal frequency and site of application. What they are saying here is, up till now, there is need for standardization of what is the optimal frequency and where are the sites that's supposed to be applied. But this is a recent, what do you call it, therapy for what do you call it, spasticity. But before now, it has been used for the management of what? Orthopedic conditions. Then medical management. We are done with anything that has to do with physical therapy. We have medical management. Oral medications. Oral medications are systemic rather than focal treatment for spasticity. What they mean here is, if I have spasticity only in the dorsiflexor muscles of the leg, tibialis anterior, should I take oral medication? No, because oral medication is going to act on all the muscles of the body. If weakness comes, every muscle of the body is going to be systemic. They are not meant for focal spasticity of either biceps or triceps. When you take it, it's going to affect all the muscles. That is one what do you call it? One limitation of oral medications. We have benzodiazepines presented by the drug like diazepam. Also, it's a short-term spasticity medication. You can use it for children that are having generalized spasticity in the body. But remember, these guys also come with another side effect. It makes the children drowsy. Therefore, whenever they are coming for physiotherapy management, if they take the drug in the morning, then the child will be sleeping until the time you finish your therapy management. Therefore, you must know if the child is taking diazepam, start taking all these anti-spastic medications. They must know the half-life of the particular drug, probably taken in the night before coming for physiotherapy. Then in the morning, the spastic muscle would have been okay to participate in regular physiotherapy. We have oral baclofen, most likely used in children, and as a long-term oral medication, progressive increase in dosage are required until therapeutic effect is obtained. What they are saying here is baclofen have longer, half-life. It will last longer, but it's very toxic. One thing is the therapeutic dose will just be added gradually until when the effective dose is gotten. We don't give high doses to children. That is why it's not very common in commonly prescribed to children. It has high toxicity. One thing is this oral baclofen that you see. We know withdrawal syndrome. It causes withdrawal syndrome in children. Just like the way people take pentazocine and all these opiate analgesics. Therefore, it's not a common drug for children because it also has withdrawal syndrome. Therefore, you give it gradually. They keep increasing the dose until the optimal effect. Yeah, okay. Okay, we are discussing baclofen. We said the dose is increased gradually until optimal dose is achieved, and for reducing spasticity. One thing we said is very toxic. It cannot be maintained in the child. Then the next is botulinum toxin injection. This botulinum toxin injection, they are of different types. Botulinum type A, type B, C, up to type F. The one that has been, cleared for management of spasticity is botulinum toxin type A. It is the most widely used treatment for focal spasticity. What we mean by spasticity is spasticity of a particular single muscle. You now identify the muscle. The child is having hip flexion. Okay, hip flexor contraction. Okay, we want to release hip flexor contractures. We have knee flexion contracture. We know the muscle. We want to relieve it. We have ankle flexion contracture. We want to relieve it. These ones are focal, spasticity. But where you have generalized spasticity in the body, botulinum toxin is not the best. The best is selective dosal isotomy. No, the best is intrathecal baclofen. Okay, toxin inhibit the release of acetylcholine in the what neuromuscular junction. Okay, generally, when we identify the child with focal spasticity and that we want to manage, this will block neuromuscular junction activity. Therefore, what we are saying is conduction of nerve impulses along the neuromuscular junction is going to be impeded. Then they said this particular block will last for up to 6 months, meaning that immediately you have the block, the muscle is going to become weak. Spasticity is going to become, reduced. Then you now do intensive physiotherapy. By the end of 6 months, that particular blockade will now free. By the time the child has achieved whatever he wants to achieve, the strength has come back, the spasticity is already gone. They say the toxin is injected directly in the target muscle and take 10 to 14 days to have what? Visible effect. Botox injection are given in conjunction with intensive therapy to obtain what? Maximum benefit. And I told you when Botox injection is administered, the child is going to have weakness in that particular group of muscles that are being injected. Now, systematic reviews for botulinum toxin injection, they said they found some evidence. Farag et al. 2020, this is recent. They found some evidence to support the use of botulinum toxin as an adjunct to other physical therapy regimen in the short term. What they are saying is they are telling us that even botulinum toxin injection cannot be administered without physiotherapy. It has to be administered. When it is administered, the patient is going to become weak. Then physiotherapy modalities must come in. Therefore, even with newer treatment techniques, physiotherapy is very, very important in the management of what? Spasticity. Then they said there is insufficient, based on Farag et al., there is insufficient evidence to support its use as an adjunct treatment to improve upper limb function. What they are saying is if you are using botulinum toxin to improve a particular limb function, apart from spasticity, there is insufficient what? Evidence. If it is for spasticity, there is some evidence. You do it, and then it will reduce spasticity to get then it as an adjunct to what? Improve limb function. You need more majorly what? Physiotherapy. But the botulinum toxin injection, what it does is it reduces what? Spasticity. But for you to improve function, you need what? Physiotherapy. That is what they are saying. Okay, and other systematic reviews, you can see some systematic reviews. One, we have two conducted in 2023, one conducted in 2011. The systematic review by Real et al. In 2011, they said botulinum toxin A, in addition to usual care or physiotherapy, seem to improve working function in children with CP. What they are saying is this particular review that was conducted some years back has found some evidence that botulinum toxin, when administered and physiotherapy our intervention follows, there will be improvement in working ability of children. Another systematic review conducted by Kumar et al., this is India, 2023, they said they compared Botox injection to serial casting. Remember, we have discussed serial casting, the physiotherapy modality that is meant for management of severe spasticity and reduced range of motion. They said they compared Botox injection and serial casting in patients with cerebral palsy, but does not find any significant difference. Meaning that even if we don't have if we don't have botulinum toxin injection as a form of therapy in Nigeria, physiotherapists can still continue with what? Serial casting. Because a systematic review that was conducted shows that the difference between in terms of improving spasticity, that Botox injection is not superior to what? Serial casting. Then they said another study, okay, the same Kumar et al. Further reiterated that botulinum toxin is expensive. For you to say your child is going to get botulinum toxin, you have to pay. It's expensive. He said also serial casting is time consuming and is usually poorly accepted by the patient because it requires you stretching and then applying cast, later breaking the cast, then further stretching. They said one is expensive, the other one is not what? Fully accepted by the patient. That is why he wants the one that is best. But finally, he couldn't find either which one is best, meaning that one can use any other one, only that one is expensive, one is not usually what? Liked by the patient. Then phenol injection. Okay, there is something that we started discussing last week when we are discussing single event multi-level surgery for children to avoid what? Birthday syndrome. I think if we can remember, last week we were discussing birthday syndrome, where at the end of every 1 year, children with severe spasticity, either in the spine or in the limbs, would have to undergo one surgery or the other. At times, for 5, 6 years, every year somebody will have, we call it birthday what? Syndrome. And then the surgeons come with what we call single level, multi-level what? Single event, multi-level surgery, such that all the surgeries and physical physiotherapy will be conducted at once. Therefore, they will do surgery in the hip, surgery in the knee, everything together at once, then physiotherapy will follow. Therefore, please, for botulinum toxin injection, for phenol injection, they are also part of single event multi-level what? Surgery in most cases. Then somebody will say, how? They can do multi-level, single event multi-level botulinum toxin injection. They will apply in a particular, like for example, a child with what do you call it, with a crouch gait, child with jump gait. Therefore, you have hip inflection, knee inflection, and ankle joint inflection. Is that also? Therefore, we have single event multi-level what? Botulinum toxin injection. They'll just do it at once. Therefore, left for you physiotherapists to know that you are going to, what do you call it? You are going to facilitate extension of the hip, extension of the knee, and extension of what? The ankle joint. You do that. And then you strengthen all the muscles. Therefore, that is single event what? Multi-level phenol. For phenol, they use for botulinum injection, they used to say single event multi-level botulinum injection. What do you call it? Injection. But for phenol, they call it chemoneurolysis. Single event multi-level what? Chemoneurolysis. Phenol injection is not reversible. Botulinum toxin injection is what? Reversible. Phenol injection is not reversible. That is why they call it what? Chemical neurolysis. Okay, now let's discuss it. Phenol injection. Phenol is an alternative option for focal spasticity management. Use alone or in combination with Botox injection, particularly in small children where body size restrict appropriate dose of Botox. Therefore, for Botox injection, you have to use high doses. Therefore, if you have very small children that you want to use on their biceps, you want to use on triceps, you want to use on hamstrings, you want to use on this, but actually the high dose is going to be too much on the child, you can use phenol what? Injection. It requires just small dose. That is all. Therefore, that is one advantage over what? Botulinum toxin injection. It requires small dose. But the disadvantage of it is the neurolysis it causes what? Irreversible. They said medical popliteal blocks are administered in the management of a child who develop what? Foot deformities. Obturator nerve blocks are applied in ambulatory children with scissoring gait. Remember, in children with scissoring gait, we have one leg crossing the other one as they are moving. Therefore, we have hip adductors. They are tight hip adductors. Therefore, the leg are crossing each. Therefore, they are being supplied by obturator nerve. Therefore, we do the nerve block so that they will be free. Okay, for phenol injection, it's not like botulinum toxin injection, please. What they do is they use what you call electrical stimulation. They would have to stimulate the nerve. They would have to know exactly. They used to we used to say electrical stimulation as guideline. Therefore, for botulinum toxin injection, they don't use electrical stimulation as guideline. But for phenol injection, because it causes irreversible damage in muscles and tissues and nerves, what it does is what they use is they use electrical stimulation as guide. They would have to know where the nerve enters the muscle. Then they will now inject at the periphery of the nerves. Then it will cause what you call it chemorrhinolysis. Please, they don't do it in the main trunk of the nerve, because if they do it in the main trunk of the nerve, then there will be total denervation. Therefore, they did it in such a way that not all the nerve that will be what? Have chemorrhinolysis. But the muscle is going to be weak. Then further intensive physiotherapy is going to strengthen the muscle. The next is selective dosal rhizotomy. Okay, the principle behind selective dosal rhizotomy, they believe that when there is heightened reflexes as a result of spasticity, then they believe the only way they can reduce spasticity is to cut off part of the neural or part of what the reflex arc. Remember, in our reflex arc, we have the motor neuron that leaves the muscle, and then the sensory neuron that leaves the muscle enter into the what do you call it, communicate with what do you call it, the interneuron, then coming back to send message through motor neuron, and then to come and activate muscle. What they do in selective dosal rhizotomy, the rootlets that are sensory are being cut. Therefore, any other heightened reflex as a result of severe spasticity is gone. But one disadvantage of it is when you cut the sensory rootlets, the child is going to lose sensation in the leg. No sensation at all. But there will be motor function. No peripheral or deep sensation in the leg. The next is the management of it requires a lot of care. But the child will always have to be wearing canvas or there is tendency that the child is going to lose some level of proprioception. Remember, dorsal column lemniscal system are the ones that control what? Proprioception. Is that also? And some sensation. The child is going to lose some proprioception in the leg. The child will have to be fitted with canvas or any protective thing. If not, he's going to injure himself. Then with extensive physiotherapy, the child is now going to bounce back. They said the goals of rhizotomy is to reduce or eliminate spasticity, improve range of motion, and improve function. Therefore, this is the surgery, severing of rootlets to alleviate symptoms. But remember, is the severing of what? The dorsal rootlets. The sensory. If you severe the motor, there is no function again in the leg. It has become lower motor neural lesion. Therefore, you severe the sensory. Therefore, that particular reflex arc and the rest is what? Disrupted. Then you have reduction in spasticity. They said the ideal candidate for the selective dosal rhizotomy is a CP child with over the age of 3 diagnosed with spastic diplegia. Therefore, these children that they tend to develop crouch gait, they are good candidates for what? Selective dosal rhizotomy. They are also good candidates for multi-level, I told you multi-level, either botulinum toxin injection or multi-level phenol injection. The child with reasonable balance and strength and motor control. Okay. Wani har yanzu ina kan yin nawa ko? Okay, am I sharing? Okay, they said the child with reasonable balance, strength, and motor control. Why do we say reasonable balance? When you cut off the dorsal column lemniscal system from getting information, what happened? Proprioception is gone, meaning that the child would always use his eyes to know when the leg is in extension or what? Flexion. Proprioception is gone, sensation is gone. He must have some balance, reasonable balance, such that when the dorsal column lemniscal system, when the dorsal rootlets are gone, then they said the child with what? Absence of dystonia or ataxia. The child who has no twisting movement of the leg. What is dystonia causing? Lack of balance. Is that also? Therefore, or ataxia, we shouldn't apply it on it. The child with CP that can cooperate post-operative rehabilitation. Yes. Child with CP who can really cooperate in post-operative rehabilitation. He has lost sensation altogether of the limb. He has lost what do you call it? Proprioception. Then definitely something is likely going to be difficult for him. Then they said the spasticity should be significant enough, causing difficulties with function, meaning that selective dosal rhizotomy is not done for mild spasticity. It is done for what? Severe spasticity. It should be significant enough to cause what? affectation of what? Or difficulty with function. If the child cannot really walk, the child is having difficulty. Now, if selective dosal rhizotomy is conducted, this is an orthopedic surgery, is that also? Is conducted, and the dorsal rootlets are removed, and the child now can walk. The parents will now not say that no, because the child has lost sensation, the child has been affected. No, it's better than him not being able to walk. Is that also? Then the next is a systematic review. We have a systematic review by Max et al. In 2023. It's a recent systematic review found that lumbosacral selective dosal rhizotomy has pronounced postoperative spasticity reduction in the lower extremities. What he said, the spasticity reduction secondary to selective dosal rhizotomy is what do you call it? Significant, meaning that it significantly reduces what? Spasticity. A systematic review is giving a thumb up for what do you call it? Selective dosal rhizotomy for improving spasticity in the lower extremity. Then the next is intrathecal baclofen. Remember we discussed baclofen, oral baclofen. We said it's toxic. We said oral baclofen can lead to what? Withdrawal syndrome. Oral baclofen can only be given in doses and gradually increase until optimal dose is what? Achieved. Here we have intrathecal baclofen. And intrathecal baclofen is usually given for a child with generalized persistence. We have children with severe CP that sitting them is difficult, doing this, what do you call it? Sitting them, standing, everything because of severe spasticity. All these are the people for what? Intrathecal baclofen. Not related to only leg or hand. Generalized what? Spasticity. They will benefit from it to reduce spasticity altogether. But remember, we said it has withdrawal what? Syndrome. They said intrathecal baclofen was approved for treatment of spasticity of cerebral origin in 1996. It treats spasticity for both spinal and cerebral what? Origin. All types of spasticity. Even if the whole body is having spasticity, it is meant for that. But what does it entail? There is a pump. Okay, let me show you this. This is what it means. The child would have a pump inserted under the skin in the abdomen. That is a large area where it can contain the pump. Therefore, you can see baclofen released into the CSF. Catheter is inserted into what? The space. We have a skin. If the drug is finished, it's like a pump that has been programmed to be releasing drug. After every, it can be programmed after every 6 hours, after every 12 hours. Are we back? Are we back? We're back. Oh? Okay, we have it. Then now,
Yeah.
one thing with this is if whenever the drug is finished, then it has to be refilled. The child would have to be taken back to the hospital, and then the medical doctor is going to refill what you call the pump. Then what are the side effects of what are the complications associated with this? We are going to discuss. They say baclofen pump is surgically implanted in the abdomen or the back of the neck under the skin to control spasticity by flushing baclofen directly into the spinal canal around the spinal cord. This is what we have. Then what are the limitations of using this thing? Some children, the pump is so big that it's bigger than the body. Therefore, meaning that they have to wait until when the trunk or the body the child has grown up a little bit, because the pump can easily be seen under the skin. That's one. The second thing is the pump malfunction may decide not to release the drug. If the pump has malfunctioned, definitely the child will have to undergo another surgery for removing and replacing the pump. And at times, the pump malfunction and release excessive dose of the drug. Another issue is the issue of infection. Yes, in trying to refill, one might introduce infection because refilling it requires injection through a needle to the particular machine. Therefore, we might introduce injection, what do you call it, infection. You know, but what the bad thing with this infection, it goes directly to the central nervous system. When you send infection directly into the infective agent directly into the pump will pump the particular agent directly into the CSF, and the child is likely going to have systemic what infection. That is one good thing with what do you call it? Bad thing with tactical baclofen. They say baclofen inhibits spasticity by blocking excitatory neurotransmitters in the dorsal horn. It maximizes the dose delivered into what you call it, spinal receptors and minimizes side effects associated with oral baclofen. Remember, we said oral baclofen has what? Side effects. This one goes directly. The candidate for this are most likely to have moderate to severe spastic quadriplegia. You can see we are discussing somebody who is having generalized, what do you call it, spasticity. Therefore, for those of us that used to manage children with quadriplegia, had it been this one is available in our hospitals, we find it easy to manage these children because it's going to reduce the severity of the spasticity. They said, and are usually for 55 years or older. Remember, we said if they are much, much younger, even the size of the pump, the skin will not be large enough to contain the pump. And usually it's inserted under the skin. Disadvantage, pump malfunction, withdrawal syndrome. And then, how do you know withdrawal syndrome? When the pump has malfunction, most especially if it does not release the drug, then the child will now be having irritability, at times some convulsions. Then you know that the pump is not working. The child will have to be taken back to the hospital for the pump to be what? Refilled or replaced. Then what are the systematic reviews that explain, what do you call it, the impact of intrathecal baclofen? The systematic review by Kudva et al. 2021 describe intrathecal baclofen pump as an all-encompassing method for treating spasticity in children with CP, as it allows for less invasive treatment that can be titrated to individual or can be tilted to individual needs. Okay, then they said it appears to be an effective method for permanent spasticity relief in young children. Therefore, wherever you have what do you call it, severe spasticity, if this particular treatment modality is present, it will give almost near permanent relief of what? Spasticity in the children. In conclusion, we said in children with spasticity, the management involves both physiotherapy, medical, and surgical intervention, either alone or in combination. This multidisciplinary approach to spasticity management is the only panacea for spasticity management in children with CP or other neurological conditions. Therefore, physiotherapists will never say that only my modality can work for the patient. Therefore, multidisciplinary approach to management of spasticity is very, very important. Oral medication plays very important, but they have their limitations. One thing, they cause drowsiness, daytime sleepiness, they make the children weak and will not participate in physiotherapy. Another side effect of them is that they are generally what? They are generally systemic. They have systemic action. Therefore, if you have focal spasticity involving some group of muscles, then you cannot use oral medications. And I know in Nigeria, mostly they use oral medication. The next is the botulinum toxin injection. We have talked about it. We have talked about phenol injection. We have talked about selective dosal rhizotomy. And then remember, in children with selective dosal rhizotomy, they have to have enough balance. They have to have enough, what do you call it, some appreciable level of strength in the lower limb. Is very, very important in these children because they are likely going to lose what we call it, sensation and perception. And then remember, we said we don't give selective dosal rhizotomy to children that have what? Dystonia. or the other one, dystonia or ataxia. Therefore, they are going to increase the balance related problem in the child. Okay. Then we talk about intrathecal pain. We say this is all encompassing. This is the most important treatment for a child with generalized spasticity. We have mixed CP, quadriplegia, and it involves insertion of a pump under the skin, and the pump will be, what do you call it, will be refilled at interval. Remember, we said oral baclofen has, what do you call it, has a significant side effect. Therefore, the side effect of oral baclofen is being taken away when it is used as, what do you call it, intrathecally, where it delivers the drug directly into the, what do you call it, into the cerebrospinal fluid. But we said it also has its own side effect. The pump can malfunction. The pump may not release drug or may release the drug at high doses. We said also through the, what do you call it, through administration of the drug through the skin may release or may introduce some pathogens or infection to the central nervous system. But by and large is the, what do you call it, base form of treatment for severe, what do you call it, spasticity of either spinal or cerebral origin. And we conclude by saying spasticity management is multidisciplinary, and it involves both physiotherapy, medical, and surgical management. Therefore, we are going to take some break. Then, when we come back, Hafiz, we are going to discuss dystonia. I think the issue is dystonia, spasticity, and pain in children with, what do you call it? Children. Go. Therefore, we'll come back 1:30. Then we now take dystonia and pain. Thank you for listening. Hello? Hello.
Thank you.
Thank you very much. And
Hello.
sir, I'm sending my greetings, sir.
Thank you so
Thank
much,
you.
Prof.
Good afternoon, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Well done.
Thank you, sir.
Yeah, thank you.
Yeah, we are going to resume by 1:30. Then we take dystonia and we take issues. Why we want to align dystonia, spasticity, and pain, because these guys, dystonia is one causes of pain, most especially in children with dyskinetic CP. And spasticity is another cause of pain. That is why we just say, let us just add pain to it. Thank you for listening until we resume. Thank you very much.
Thank you, sir.
Wannan slide ɗin sai na kai awa ɗaya da rabi ko awa biyu ma na haɗa shi. Okay, welcome back to the little break that we had. We are going to continue. On dystonia. Yes, okay. Okay, this afternoon lecture will be on dystonia, and we start. Initially when I started at the beginning of the previous lecture, I said we are going to look at dystonia. Then we are going to look at spasticity, dystonia, and pain. And I said why pain come in between is because both spasticity and dystonia causes pain in patients with neurological disorders, most especially in children with neurological disorders. We are done with spasticity, but remember, individuals with neurological disorder can present with either dystonia, and dystonia can occur as a cascade of events in children with this kinetic CP, which we are going to look at. Um, remember, we said individuals with what do you call it, upper motor neural lesion can present with spasticity, they can present with rigidity, they can present with dystonia, and then the different types of rigidity, cogwheel, late pie, clasp, knife, all these stuffs. But the issue is we are discussing dystonia, which is another cost of what do you call it, pain in children, and another cost of reduced range of motion in children, another cost of what do you call it, abnormal movement in children. By way of definition, we say dystonia is characterized by involuntary contractions that lead to abnormal posture or movement. Therefore, and I used to remember the basic difference between dystonia and spasticity. For children with spasticity, they say spasticity you see. Spasticity you test, you feel. Dystonia you see. Okay, the difference between spasticity and dystonia on a quick assessment is in spasticity you test, in dystonia you see. Then what are you really seeing in dystonia? What you are seeing in dystonia is persistent movement, continuous movement of limb and trunk, twisting movements. Immediately you see that, this is likely going to be dystonia. It may complicate extrapyramidal CP, the one we call dyskinetic CP. But in spasticity, the child is usually stuck in one place, not moving, most especially those with severe CP, until you begin to move the limb. You now feel that, the muscles are very spastic. That is spasticity. But in dystonia, you don't have to touch the child. You see the movements. When you begin to see the movement, this is kinetic CP, this is likely going to be dystonia. It depends on the type. They said depending on its underlying cause, dystonia can manifest as primary, hereditary, idiopathic, or it occur as secondary consequence of neurological disorders. Therefore, majorly what we are discussing is dystonia that it occur as a result of what? Secondary consequence of neurological disorder, mostly in children with either what do you call it, pyramidal insult, like, but majorly it occurs as a result of our extrapyramidal injury in children with basal ganglia damage. Therefore, majorly we are talking about what? Neurological, the one that occur as a result of what? Neurological disorders. You can find all others. Then we can have dystonia associated with CP. Yes. Therefore, there are so many ways we classify CP. We can classify CP. We have the one we call topographical classification. In topographical classification, we classify CP based on the number of limbs that are affected. You can have monoplegia. Usually in literature, they say the monoplegia is usually a hemiplegia, but what usually happens is the legs are mildly affected. You can never see. Usually, the most symptom appears in the hand. Then we have diplegia, where the two limbs are more affected than the two lower limbs are more affected than the upper limb. Then we have triplegia, where three limbs are affected and one limb is spared. Then we have double hemiplegia, where you have all four limbs are affected, but the two upper limbs are more affected than the two lower limbs and asymmetrically. Then we now have this added what you call topographical classification. Then we have physiological classification, which we are going to deal with in this lecture. The physiological classification, we classify them based on the area of the brain that is damaged. We have pyramidal that leads to spastic type of CP, meaning that the spasticity we have dealt with in the other lecture is as a result of pyramidal tract damage, damage to internal capsules, damage to all the nerve fibers that pass through the medullary pyramids. Then we have hyperkinetic. Another name for all this type are what we call hyper or dyskinetic. They're extrapyramidal, extrapyramidal. Therefore, we have usually they occur as a result of damage to extrapyramidal pathways, most especially subcortical structures such as the basal ganglia and its lentiform, coded nucleus, globus pallidus, and all these parts. Then we have ataxic, it's also extrapyramidal, usually comes as a result of affectation of what do you call it, the cerebellum. And we have mixed, where you have signs of both pyramidal and extrapyramidal. Why we brought this thing is because the ones we see, the children that are continuously in motion, they are what you call the dyskinetic CP types. Then somebody would say, yes, usually, even from history, even without beginning to see a child with your own eyes, if somebody call you on phone, you would be able to say whether this child is likely coming with dyskinetic or spastic CP type. But let us concentrate on the dyskinetic CP type. When somebody tells you that we have this, like for example, a mother coming to the clinic telling you that actually what happened to the child when the child was young, some few months after birth, the child develops yellow eyes, and then he was given medication, at times transfusion, at times phototherapy, but the child end up having what do you call it, a cerebral palsy. You know, it's an extrapyramidal CP. It is what do you call it, jaundice. There is what you call canicterus. There is crossing of unconjugated bilirubin across blood-brain barrier that causes extrapyramidal CP. Or there is what you call hemolytic disease of the newborn, where the pregnant woman has what do you call it, rhesus factor negative, and the child has rhesus factor positive. In a way, after the first delivery, the second child, if he has rhesus factor positive and the mother is having negative, the antibodies in her body would cross and enter what do you call it, the bloodstream of the child, and then that will lead to hemolytic, what you call erythroblastosis fetalis. The child is likely going to develop extrapyramidal CP. Some of what do you call it? These are few examples where you have basal ganglia directly damaged. And then another way of getting this is, I told you for spastic CP, the child will be calm, and then until you test, you now begin to know without this spasticity. But for extrapyramidal, it's not like that. What usually happens is that the child is usually in motion. Then we now move to dyskinetic CP types. refers to increase in muscle activity that results in excessive abnormal movement, excessive normal movement, or combination. Therefore, here in this kinetic CP type, we can have combination of two, excessive abnormal twisting and excessive normal movement. Excessive normal movement, the elbow joint is moving into flexion and extension, but when flexion and extension is needed, probably to carry something and put into the mouth. And then when flexion and extension is done several times, it's excessive normal movement, where the movement is then twisting, like snake, twisting and twisting, then it has become excessive abnormal movement or combination of both. Then when you see that, you know this is hyperkinetic or dyskinetic CP type. And then this dyskinetic CP type is characterized by three things: dystonia, atetosis, and chorea. It is not likely for most especially in small children, it's not likely to see pure dystonia. It's not very likely, most especially with those coming for therapy, but you may have combination of dystonia and atetosis and chorea, chorioatetosis, all these guys, but you may still have some children with dystonia. Yes. Okay, now dystonia is a sustained or intermittent muscle contraction causes repetitive and twisting movement. The twisting movement can be in the neck region, somebody raising the head as if it's a snake. It can be in the limb, somebody moving the hand as if it's a snake. And then that movement, even from the vision, even from what you see in physical examination, you know that child is also having what you call it, hypertonicity. Then we now have atelectasis, uncontrolled slow rhythm movement without recognizing movement, what you call it, fragments. Okay, this is very, very important. When there is movement, the movement is slow. There is no fragment in the movement. There is no time when somebody stop and continue the movement. That is fragment. Then that is atelectasis. But when there is sustained movement, when somebody will reach the end, stop, then come back, reach the end, stop, then come back, that is dystonia. Then usually atetosis, usually we see atetosis most especially in the extremities, the hands. At times the hands, the leg, but not the entire limb like that. Usually you can see atetosis in the forearm, in the hand, and all this. Then we have chorea. This is a B2B. This is what you call dancing, uncontinuous, explosive dancing movement. Somebody's hands and leg keep going, coming down. This is explosive dancing movement. It's entirely different from the two. An ongoing random appearing movement. Immediately you see chorea, it's easy to recognize. It's involuntary movement with a lot of fragments. Dancing hands, dancing leg. This is chorea, is what do you call it? The child is in chorea is also in constant motion. Then the differences in atetosis is distinguished from dystonia by lack of what? Sustained posture. What is sustained posture? You move the limb in outward position like snake, but when the child reaches the end, he will stop for some time, then come back. That is dystonia. Therefore, but in atetosis is gradually moving like snake, but there is no fragments. There is nothing like stopping and coming back. It's like in continuous motion like this. You can see somebody's hand moving this way. Let me show you my something. Okay, can you see me? Okay, in atetosis, you can see my hands. The hands can be moving always in continuous movement. Look at my hand, always in continuous movement like this. There is no fragment. But in dystonia, the hand moves, stop, then come back like snake. The hand moves, the body can also move, the leg can move this way, sustain, then come back. Therefore, there is fragment, there is stop, then coming back. But this one is a continuous motion in what do you call it? In atetosis. Then we have chorea. We said chorea is distinguished from dystonia due to an apparent random, unpredictable movement. The movement is not like snake-like, it's unpredictable. Hand and leg keep moving upside, that is chorea. Continuously ongoing move. Dystonia has predictable stereotype movement pattern. That is one thing with dystonia. It has one stereotype movement pattern. And when it reaches the end, there is sustenance of that particular, that is what we call sustained posture, moving to the end, stopping before it comes back. Then in athetosis, it's the same slow movement, but it has no fragments. It just always moves like this. Then that is it. When we have children with hyperkinetic CP, you either see chorea, athetosis, or dystonia. And in some, you have combination of choreo, athetosis. There is elements of athetosis and there is elements of what? Chorea. Then pathophysiology, what causes this, what do you call it, dystonia? Is lack of cortical inhibition arises from what? Basal ganglia dysfunction. Therefore, whenever the basal ganglia is damaged, it's a subcortical structure that controls movement. The initiation of movement is your cerebral cortex. But control of movement is basal ganglia. Therefore, it's inhibition of what? This control of unwanted movement. The disinhibition of basal ganglia is what causes, what do you call it, unwanted movement. Here they say typically, dystonia is triggered by or worsened by voluntary actions and associated with overflow of muscle activation. What they are saying here is whenever a child is to perform a particular movement or particular action or is to carry out a particular movement, that particular initiating a particular movement may trigger dystonia. That is why part of the management of dystonia is a relaxation technique. Relaxation is part of the management of all these hyperkinetic disorders. Relaxation practice, relaxation technique, the child to be able to take control over his own movement rather than you imposing a particular movement is part of their treatment. Therefore, triggering, what do you call it, excessive, what do you call it, voluntary action can trigger it. The disorder may present with a range of challenges, and the most important challenge number one is pain. Just like the patient with spasticity, people with dystonia, either cervical dystonia or focal hand dystonia, they can present with pain. They have some form of depression. Yes, when you see somebody with strong dystonia that is always bending, not be able to raise in the head, how can he walk with bending forward? Or how can he walk with bending sideways? It gives somebody depressive symptom. He want to walk in like other people. He want to walk without his limb, hands moving around. Then we have anxiety, social stigmatization. People calling him disabled. We know in our society, we have a way of calling people names. Look at this disabled. Look at this leper. Look at this. Then reduce self-esteem. Somebody feeling that he is not, or he does not have self-worth. He is not equal to others. He is of less value. That is it. Then we now have classification of dystonia. We have majorly two types of dystonia, but please, we are classifying dystonia of neurological origin. Remember, there is idiopathic dystonia, we have hereditary dystonia, all these ones. We are limiting ourselves to what we can handle. Here we are saying of what do you call it, neurological origin. They are divided into two main subtypes based on clinical manifestation. We have motor dystonia and postural dystonia. All of them are motor, but the ones we call motor dystonia, they are what we call majorly focal or generalized dystonia. Motor dystonia, they affect movement. Why we call them motor? They affect movement. They affect, can we say, movement of extremities. Hands and legs, we call them motor. The postural dystonia does not have to do with movement of hand and leg. The movement of hand and leg is not the most important. It's movement of the trunk. If you see somebody bending forward as if he wants to take something between his legs, and that is the way he wants to move, then there is a problem. Or somebody tilting sideways, or somebody's neck tilting forward, then there is problem. Those ones are what we call postural dystonia. Therefore, motor dystonia can be what? Generalized or focal. The focal, remember what we said about focal spasticity when it affects one group of muscle or one segment of a limb. The same thing with this, where you have cervical dystonia that affect only the neck. Only the neck is moving like snake. That is cervical dystonia. Okay. Now we have more. We now come to motor dystonia. We say it's characterized by abnormal muscle tension during twisting movements. Remember, dystonia is associated with twisting movement. Therefore, They said abnormal muscle tension, resulting in involuntary twitches and tremors across various body regions. This is motor dystonia. And then this movement are often worsened during voluntary action. They are telling us that excessive movements, physiotherapist prescribing do this, do that, may always trigger more dystonia. Therefore, quiet, well-planned movement controlled by the child with enough relaxation is what is required. Affecting motor function causing what? Dyskinesia. And then whenever you hear dyskinesia, remember dyskinetic CP. Abnormal, unwanted movement that are random and ongoing. That is what you are likely going to see. There is a motor dystonia can be focal, affecting specific part of generalized involving multiple body parts. Then focal, we give example is what? Writer's cramp, focal hand dystonia. Yes, for people that are used to doing either carpentry or somebody playing piano or guitar or anything, when they develop dystonia, then they have some people develop focal hand dystonia, or they call pianist hand dystonia. Somebody, then it involves usually treatments like what do you call it? There are researches that shows that there are promising results even with CIMT, that one can easily train somebody with focal dystonia using CIMT. Cervical dystonia, we have said, involving the neck muscle. And task-oriented dystonia. What is task-oriented dystonia? It's a specific dystonia that occur as a result of certain tasks. You ask somebody to do it, he has dystonia, but if it is a particular task that involves taking something or lifting something, then the dystonia will come. That is task specific. It's related to somebody, like for example, musician's dystonia, playing an instrument. Whenever what do you call it? Somebody is doing something as if he's playing an instrument, then the dystonia will come. That is task specific dystonia. Then we have general dystonia that affects various parts of the body, but remember, this is not focal. It can affect usually in children with extrapyramidal CP. Most of them develop generalized dystonia. We see somebody, the whole body is moving. You now have generalized dystonia. That's the whole body, the limb and the trunk and all these ones are moving. That's generalized dystonia. But in some, you now see only the limb is moving, no trunk. Then the next is truncal dystonia, or what you call postural dystonia. Postural dystonia is characterized by a typical and sustained posture without repetitive extremity muscle movement. What we are saying is this is a dystonia that affects the trunk. You are not likely going to see all the desired movements in the hand and leg. Now the movements are restricted to majorly the trunk. Then somebody will ask, why is cervical dystonia not part of it? Because cervical dystonia, but still only the neck. Remember, it affects only one segment of the body, only the neck. Then if it is only the neck, then it is being classified as a focal dystonia affecting only the neck. Example is what we call camptocomia. Here, we call it bent spine syndrome, forward bending of the trunk. Somebody, you ask somebody, and one thing is, he can stand, but when you say walk, then the spine will go down, as if you want to take something behind his two legs. That is, what do you call it? Postural dystonia. We have PISA syndrome. The PISA syndrome is lateral bending of the trunk, as if somebody is having a hip pain on one side, will just be bending on the other side. Then we have anticolis. Remember, we have torticollis, we have retrocolis, we have anticolis. Means anticolis is forward flexion of the neck. Somebody is having dystonia, but the whole trunk and the neck is, what do you call it? Bending forward. This is postural dystonia. These postures become more pronounced when individual tries to stand or walk. Then measurement of dystonia. Now we have measurement of dystonia just like spasticity, but these guys can also be used in children and adolescents with dystonia. We have Barry Albright dystonia scale. This is the first scale that is being produced to assess dystonia. And there are some quarters, some researchers, just like the way modified Ashworth scale was criticized, that it does not measure spasticity, it measures muscle tone. Yes, Barry Albright dystonia scale was also criticized, that it measures, what do you call it, spasticity, not dystonia. That the way it is measured, it is as if it is modified Ashworth scale, Therefore, it is like measuring more of spasticity than dystonia. Therefore, there are all these, what do you call it, limitations. But still, up to now, Barry Albright dystonia scale is being used to measure dystonia. Then two other ones, new ones are produced. We have the hypertonia assessment tool. This hypertonia assessment tool discriminates between hypertonia subtype. It helps them to separate dystonia from spasticity. Usually, all the questions are there. Then they will ask whether the child has sustained posture, whether the child has velocity dependent, what do you call it, resistance passive stretch, whether he has this. Then, as you are testing, then they'll tell you if he has this, then this is spasticity. If he has this is dystonia. Therefore, the scale comes with both spasticity and dystonia, and tries based on the items, you can differentiate whether the child is having dystonia or spasticity. Then we have dyskinesia impairment scale. Yes, it's a new scale also. I think they have 20 items. When one uses them, he can easily differentiate between, based on the scoring of the child, he can easily differentiate between spasticity and dystonia. Now, management of dystonia. How is dystonia managed? We have started saying that there are some researches that look at CIMT, some researches look at what do you call it, relaxation techniques in addition to self-control of the movement by the child. Here we deal with systematic reviews that actually look at so many studies that manage, that are presented with RCT that manages individuals with dystonia. The first systematic review is by Pao et al. 2013, which reported that physiotherapy treatments such as EMG biofeedback, muscular elongation, meaning that muscle elongation, can we say assisted muscle elongation gradually for somebody to be, what do you call it, assisted in this elongation. Then we now have electrotherapy. Also, they said improve cervical dystonia. What they are saying is for individual that has cervical dystonia, EMG biofeedback can work. Probably a common mirror, physical biofeedback can also help the individual be seeing his movement and correcting his movement. Then we have muscular elongation, a little bit of stretching on the other side, postural exercises also, then electrotherapy. They said combination of these guys help health motion, reduce pain, what do you call it, improve range of motion in the neck, quality of life, and ADL. Therefore, these are reported by Pao et al. 2013. But these researchers advise that before firm conclusion can be drawn, additional high-quality trials are needed, meaning that we cannot rely 100% on the results they have seen, because probably the studies that they include in their systematic review, they are not of high quality. Therefore, they advise that high quality trials can be conducted to see whether EMG biofeedback, muscular elongation, postural exercise, and electrotherapy can improve the condition of patient with what? Cervical dystonia. Then we have systematic review by Anke and Posky et al. 2018. They reported moderate evidence, meaning that there is some appreciable, what do you call it, evidence to support effectiveness of neuromuscular education programs. They are mostly physiotherapy modalities. They say constant induced movement therapy plus motor control training. Therefore, you do some motor control training and constant induced movement therapy. Then they said sensory motor training. Therefore, probably some tactile stimulation, sensory motor training. Then they said learning-based sensory motor training, slow down exercise. We can now see this slow down exercise is a relaxation exercise. Slow down exercise. As somebody is moving, you now say, okay, you keep moving, but don't touch this one. Then you now put something, you now keep moving with him without him touching that thing. Slow down exercise, let's come back, such that the individual should be able to control the limb that is in constant in motion. They said they are effective in reducing abnormal movement during instrumental play in musicians with focal hand dystonia. Therefore, you can see the first one talk about cervical dystonia, the second, what do you call it, systematic review talk about focal hand dystonia. The third one is a systematic review by Rodriguez, 2019, reported that there is low quality evidence for deep brain stimulation. Here we are talking about deep brain stimulation. Actually, there are two, what do you call it, techniques outside physiotherapy that are employed or they are administered to individuals with dystonia with some proven efficacy. The first one is deep brain stimulation, and the target of deep brain stimulation is non-invasive. Therefore, you can apply, there are some form of deep brain stimulations that you can apply using electrodes across the head, but the target should be the globus pallidus of, what do you call it? The globus pallidus nuclei of the basal ganglia. Then the other treatment is what was obtainable in the management of spasticity, botulinum toxin injection. I think is still part of the management of, what do you call it, dystonia, meaning that botulinum toxin injection can be used to manage both dystonia and spasticity. Therefore, for deep brain stimulation, the Driggs et al. 2019 reported that there is low quality evidence for deep brain stimulation of globus pallidus nucleus in reducing symptom severity and improving functional capacity in adults with cervical, segmental, and generalized, what do you call it, moderate to severe dystonia. What he is saying is whether adults, whether children, if for cervical, segmental, and generalized dystonia, that globus pallidus may have some effects, but actually there is low quality evidence. What is there is probably there is conflicting, what do you call it? There is conflicting report from systematic from randomized control trials. Others saying positive, others saying negative. There is likely that you now say there is low quality evidence. Then we now move. The finding of systematic review by Zeng et al. 2025 highlights that DBS, especially when targeting basal ganglia or innovative targets, shows promise as a therapeutic approach for dystonic CP. Therefore, this systematic review was conducted specifically for children to get the impact or the influence of deep brain stimulation on dystonia in children with CP. Remember, we said children with CP can develop dystonia as a complex, what do you call it, interrelationship with other forms of, what do you call it, dyskinetic CP. They said a thorough evaluation of long-term efficacy remains crucial. What this systematic review is saying is that though deep brain stimulation it shows promising results in improving dystonia in children with cerebral palsy, what he is saying is that not much is known about on the long-term effects of these different, what do you call it, stimulation in children with cerebral palsy. Then another systematic review by Fan et al. They found that globus pallidus internus stimulation and subthalamic nucleus stimulation were both safe and resulted in excellent improvement in efficacy and quality of life in patients with dystonia. What they are saying is the dystonia, what do you call it, the results of their systematic review found that deep brain stimulation is safe, meaning that safety first is safe to be administered on patients. That is number one. And the second thing is they said it results in improvement in the dystonia symptom and also in their quality of life. Here they said compared with segmental dystonia, patients with focal dystonia demonstrated better improvement in dystonia symptom. This is a further explanation by Fan et al. That meaning that the stimulation of globus pallidus internus and subthalamic nucleus results in better improvement in what? Focal dystonia compared to somebody who is having what? Generalized dystonia. Meaning that somebody who is having cervical dystonia, focal hand dystonia is likely going to improve in his dystonia compared to somebody who is having generalized dystonia. That is what these guys are saying. Now we have Botox injection, botulinum toxin injection. Remember, I have said it. It has been used in several researches with some promising results. in children with dystonia. Systematic review by Ludovic Krug et al. 2022 reported in the review regarding additional PT to basic botulinum injection therapy shows possible benefits for patients suffering from cervical dystonia, while the effect of physiotherapy on posture still remain for update. What they mean here is that combination of botulinum toxin injection and physiotherapy after the injection shows promising results for individuals suffering from cervical dystonia. But they said the effects of physiotherapy on posture, meaning that postural correction, all this one is still up for update. What they mean is that there is need for more research to be conducted. Then adjuvant drugs. What they mean here is, aside from management of dystonia itself, dystonia presents with a lot of problems, probably joint problems, pain. Therefore, there is need for analgesics to be administered where there are secondary complications. Also, when the painful dystonic muscles cannot be sufficiently suppressed. Therefore, when somebody is having persisting dystonia despite treatment, then he has to be helped with analgesics. Finally, anxiolytics can be used to reduce stress as dystonia facilitating factor. Therefore, when somebody is under serious stress because of pain or anything, pain can increase the dystonia. Therefore, he can be given anxiolytics to reduce the stress so as not to evoke dystonia. There is something, remember we said in the previous lecture that spasticity has its positive sides. The positive side of spasticity, we said it maintains the muscle bulk, that it does not lead to severe wasting of muscle spasticity. Two, it maintains bone mineral density. Therefore, the hands and the legs of children with spasticity don't break easily because of the inherent electrical activity in the muscle that keeps the muscles moving. Then we said the extensor thrust in the leg used to help most especially children with hemiplegia to stand. Then dystonia also had its positive side. One, dystonia does not produce contracted joints like spasticity. Spasticity can lead to decrease in range of motion of joint, can predispose to contractures, can predispose to joint stiffness. Dystonia, the individual is always in motion. Therefore, there is nothing like contracture. There is nothing like reduced range of motion in dystonia, only continuous movement. It also does not come, meaning that it's an advantage over spasticity. Then it also does not lead to excessive muscle wasting. We don't have that because of excessive motion. It's like continuous exercise. It also helps to preserve bone mineral density. Then in conclusion, we said for children we are managing or adolescents, they may likely present with pure dystonia. They may likely present with dystonia that is dystonia mimicking together with other forms of dyskinetic CP, atetosis. We can also have chorioatetosis. I remember in the dystonia is caused by extrapyramidal lesion, mostly affecting the basal ganglia. And we said the therapy modalities for the management of dystonia. For now, based on some systematic reviews, it says based on the quality of studies, more studies are needed. And remember, we said it's a multidisciplinary also approach. Multidisciplinary approach to the management of dystonia is desirable because there is need for medical management in addition to physiotherapy management, optimal management of this patient. Therefore, management of dystonia also is multidisciplinary. Physiotherapy and medical treatment are required for optimal care. Thank you for the listening to the second part of the lecture. Okay, I'm going to take 20 minutes to rest. Then I now take the last part. Go. Hafiz. Okay, thank you for listening. I have taken the second part of the lecture. We looked at dystonia, and the last part of the lecture, which is the shortest, we are going to look at pain, and which is the connecting factor between Ya hauko? Okay. Uh, Good afternoon. Hello. Hope we are together. Hello.
Yes, sir.
Okay. Because of network, at times I may just be talking and people may not hear. Okay, we are going to discuss on the little about pain, and we said, okay, can you say you welcome me back? Because I was the one that take a little break. We are discussing pain, and we say what joint dystonia and what do you call it, spasticity are two, or can we say are threefold, not two? The first is they occur as a result of upper motor neural lesion. Both of them, spasticity occurring as a result of pyramidal tract insult. Then dystonia occurring as a result of extrapyramidal, what do you call it, insult. Then that's one. They are all as a result of brain damage. The second thing is they all cause hypotonia in the muscles. And the third link between them is that they cause pain in muscles and joints. That we should discuss something little about pain. I would say, by way of introduction, pain has been defined by the International Association for Okay, we are back. The network was unstable, but can you hear me? Hello. The network is not
Yes,
stable.
sir.
Okay. Yes, we said pain is defined as unpleasant sensory and emotional experience associated with actual or potential tissue damage or be described in terms of such damage. Therefore, we say something unpleasant, something that you really that gives us irritability. We don't like it. It can be sensory. It can be something that somebody slaps you. That is sensory. You feel the pain. Somebody who put hot something on your skin. You feel the pain. That is sensory. Emotional has to do with pain you feel inward when somebody died. Is it your husband? Is it your child? Is it that somebody wants to give you money, but somebody now went and hijacked the money? That one is an emotional pain. You feel pain inside. That is not physical. And then it is associated with actual or potential tissue damage. Actual tissue damage is when you cut somebody's skin and you say, okay, this is damage. Or you hit somebody and blood comes out. That is actual tissue damage. Potential tissue damage is when you apply tourniquet in your hand. And then that particular tourniquet impedes blood supply. And your skin will now begin to give you pain. Yes, you now say, okay, it's a potential. If you do not relieve the pain, then tissue damage will occur. Or described in terms of such damage. Then what do we describe in terms of such damage? We now say leg pain, neck pain, what do you call it? What type of pain do we say? Hip pain, labor pain. We say what do you call it? Therefore, we describe in terms of such damage, post-operative pain. All these ones are described in terms of the damage. Okay, now some people feel that something is wrong somewhere. Of recent, in 2020, there is revised definition of what do you call it, pain, by the same International Association for Study of Pain. They define it as unpleasant sensory and emotional experience, just like the other one, associated with or resembling that associated with actual or potential tissue damage. Now, what they said is something has to be removed. Remember, there is something we said or described in terms of such damage. Yes, they removed that. They said this revision resulted in decreasing the emphasis of pain associated with tissue damage. They believe that pain does not always is not always associated with tissue damage. They said in the definition, and by removing the word describe, allowing those who were nonverbal to be assessed using other validated pain scores. What they mean here is that there are some people that cannot say this is where the pain is. We cannot say leg pain because they cannot say my pain, but most especially in children with severe motor disabilities. They cannot say my hand is paining, my leg is paining. Probably they begin to do some movement. You know that they are probably inside pain. Therefore, they said, that is why they say resembling or associated with. What does that mean, resembling? Like, let me give you one example. You meet somebody who is older than you, probably a very big personality, that he is not expecting that you should shake him. He is expecting that you should bow and greet him. And you now give him hand and you shake him. You now saw something in his face as if he didn't like it. That is resembling emotional experience. He is so shocked with what you did. You're supposed to bend down as what do you call it, a big person to greet him, but as a young person, you just give him, you shake his hand as if he's your mate. Therefore, therefore, resembling what this guy did in his face is resembling pain that he's feeling, but not actually, but he is really having pain. The same thing with Okay, can you hear me? Can you see the slides?
Yes, we can hear you now.
Okay, welcome back. Can you hear me? Okay, the network wasn't stable, but we thank God at least we are back. We are done with the definition and the reason for the revised definition. They said pain can actually be, what do you call it? Can result from actual tissue damage or potential tissue damage, and pain can also occur in individuals who cannot report pain. Therefore, the definition has to be revised, and that is the reason why the phrase resembling that associated with or actual or potential tissue damage is included, such that individuals that cannot report pain, most especially those with severe mental retardation or what do you call it, severe cerebral palsy, using a validated instrument. Okay, the next is causes of pain. If we lump them together, causes of pain in children can be due to physical injury. Somebody would have either a fall or an accident or anything that causes physical injury. It may be associated with pain. Disease process and infection, osteomyelitis, what do you call it? Uh, Rheumatoid arthritis, idiopathic, juvenile rheumatoid arthritis, all these, it may be a disease process, infection, all these. Complications of neurological impairment, it can be from spasticity, dystonia, or rigidity. One can get pain from that one. From neoplasm, cancers. Yes, from neoplasm, cancers, children with, what do you call it, cancers also used to have serious pains. Therefore, there are so many causes of pain in children, but these are a few that we mentioned. Then, assessment of pain in children can be challenging, most especially if the child is incapable of self-report due to developmental disabilities. What we are saying here is, it's easy if a child is grown up and you're not giving visual analog scale, and we said, okay, you rate your pain from 0 to 10. 10 is the maximum pain imaginable. 0 means no pain. And we ask that individual from the distance of that 10 centimeter to pick where the pain is. It's easy. Okay, we are back again. Can you hear me? Okay, I think we have to move fast because the network is really very bad. Let me see if we can. Okay, is there information that somebody is talking? Ko duba gani. Okay, we said assessment of pain in children can be challenging, especially if the child is incapable of giving self-reports due to developmental immaturity or disability. Then how can the physiotherapist assess pain? The experience of pain goes beyond determining pain intensity and includes physiologic and behavioral indicators. What they are telling us here is, remember the reason for revising definition of pain by IASP. It doesn't have to do with actual tissue damage or potential tissue damage when something is likely going to, it's just eliciting pain, but it's telling you that when that pain is increasing, the tissue damage is occur. No, they are telling you that there are individuals that are incapable of reporting pain, but there are some behavioral indicators that will tell you that these guys are having pain. Therefore, that means that scales have to be produced. That does not warrant you asking somebody what is your pain and where is your pain. But you can still assess pain using some of the behavioral, responses of these patients. Children and adolescents with chronic pain suffer from disability. Therefore, remember part of the gaits we talk about, there is antalgic gait. Somebody is having pain, but he'll be working on one leg, nearly just putting the other leg small on the ground. Therefore, some pains as a result of disease process, probably cancer in the limb, anything can happen. Therefore, they are part of a disability. They can cause disability. 2, they can cause low mood. Somebody will just feel he is not feeling okay, low self-esteem, poor socialization. If somebody is suffering from pain, may not be able to mingle with other children, most especially a small child, may not be able to mingle with other children. You now have inability to exercise or participate in physical activity. Yes, children are encouraged to do exercise even in school, PE, physical and health education in school. Therefore, they are encouraged. If somebody is having pain, he will not be able to do that. They're missing school. For pain reasons, children that are going to school may not be able to attend school. Therefore, children and adolescents that suffer pain may also experience this. Then we said majority of children with neurological impairment experience pain as a common symptom. Therefore, we say dystonia or head injuries, we talk about even children with sickle cell disease. Majority of children that we see in the therapy department, they are likely going to report pain as part of their symptom. The highest frequency and severity of pain occurs in children with the greatest impairment. The more the impairment, the more the affectation, the likely the pain. Then, if all recognized and untreated, chronic pain adversely impacts on activity, participation, and quality of life. Therefore, if we as therapists we are unable to recognize pain that these children are suffering from, we are only interested in movement, we are only interested in range of motion, we are only interested in muscle strength, but we do not recognize that these guys are undergoing pain. Chronic pain can impact on their ability to even participate in the therapy, ability to do home-based exercise, ability to function. Then it may impact their ability to participate and quality of life. It may reduce their quality of life. Now, there is another chapter. Though we are not mental health experts, but we should be equipped with ability to recognize one subtle, pain that they feel. It is not always physical. That is the reason why they talk about it. Remember, pain can be emotional. They said, therefore, we don't say that a child of 2 years does not have emotional feeling. Yes. When you are giving people chocolate and he comes and he says, I'm not going to give you, you start crying. That is emotional. He may be feeling pain in him. Why is this man not giving me chocolate? Therefore, a child of 2 years can also have emotional feeling. He can have anxiety, he can have depression. What they are telling us here now is, still we go back to that definition. Remember we said an unpleasant sensory or what? Emotional experience. That emotion can be felt by children. They said the importance of mental health condition, worsening pain in young children is often overlooked. We always want to do physiotherapy, but usually we have to do mental therapy. We have to communicate with this child, sit him down. What are you feeling? Why are you not participating? Is it because of pain in your leg? Is it because of this? Is it because of that? Why are you not participating? Then you'll now be able to know what is the cause of pain. Children as young as 2 years can experience anxiety and depression and manifest primarily with what? Withdrawal behaviors. Not wanting to do this. Things that you are doing, not wanting to do it. Somebody that is used to joking and everything, not wanting to do it. Therefore, probably the depression and anxiety somebody is having is hiding the little pain he is feeling. Therefore, in essence, it's not always physical. We can also get mental. We can also become friendly with the child, friendly with the mother in order to get more information on the psychological frame of mind of the patient. They said anxiety and depression can result in neurophysiological changes, altering pain perception. Therefore, the little pain you feel that it shouldn't be much, the child will be feeling it as big because he is also suffering from anxiety and depression because of some other issues. Therefore, it's not bad when we refer. It's not always that we refer somebody who is elderly or is adult to the psychiatrist for further management. Yes, some of them will benefit from tricyclic antidepressant and some of these drugs that can be prescribed for them. But the most important thing is not always physical. Pain can be mental. And another thing we should understand, pain can occur, anxiety and depression can alter the pain perception in these children. Little pain can become big because of the child having some anxiety or depression. The prevalence of pain. The pain prevalence varies from 14 to 76% in children and young adults with neurological disorders. Therefore, young adults with neurological disorders either upper or lower motor neuron lesions that are coming to our clinic, because majority of the children coming to therapy, more especially in pediatrics, the majority of them are likely going to be neurological. About 14 to 17%, according to McKinnon et al., are likely going to report some pain. They said pain is more prevalent in female, other age groups, and children with gross motor function classification system 5. What they mean here is, when they say it's more prevalent in female, it's not because their female feel pain more than male. No, they tend to report pain more than male children. Male children are just too playful. Therefore, they can even forget the pain. But female children can always report. Take in our example, males or the parents at home, take the example of the father and the mother. The mother can always go to the hospital because of little pain, and that is why they can easily get diagnosed. But husbands, before they go to hospital is another thing. Probably when they take him on stretcher. That is it. It's the same thing with children. Female can always present. That is why the prevalence is higher. Then older age group. And older age group are more mature. They can easily say, this is where my pain is. I'm suffering from this. It is understandable. And then children with gross motor function classification 5. What is gross motor function classification 5? The least functional group. You know, gross motor function classification 1, they are the most functional. They can romp, jump, and they can climb stairs without holding rail. Gross motor function classification 2, they are the second group. They can walk, they can climb stairs but holding rail, and they can walk majorly within the house but not outside. The third group, they are the ones that work using handheld mobility device like walking frame, like crutches. Classification 4, they are the ones that use wheelchair and they can propel themselves, but they cannot stand and walk. The fifth one are the least one. Usually they are not functional, the severe ones. Due to some assessment using some pain scales in this guy, they believe that, and actually I agree, because most of these guys are having severe spasticity. Probably they are the ones with gross motor function classification 5, the least functional. They tend to suffer from more severe spasticity and pain. That is why they have it here. Then pain outcome measures. What are the outcome measures we use for assessment of pain? The outcome measures we use for assessment of pain varies with the varies with the cognitive ability of the child. The first one is the flag scale that we use for infants. And please, the first one, not the flag scale, the premature infant pain profile. Therefore, if you Google it, you are going to see it. It has a maximum of score of 61 by 21, 0 to 6 points. Minimal score or no pain is 0. Therefore, the maximum score is 6. Therefore, the total score is 21. Any score greater than 12 is moderate to severe pain. Therefore, they use behavioral movement of the child, the movement of limb, the groaning, the crying to ascertain pain. Then we have pain in children. We have the face, leg, activity, cry, and consolability behavioral tool. We call it the flag scale. It can use to assess pain in normal as well as in cognitive impaired children. Therefore, if we go and search FLACC, we are going to see the flag scale. Then we have pediatric pain profile. Okay, this one has also 20 items. It can also be used to assess pain. Then the next is for children, we have 5 years and above, we have one Baker face scale. We see some face, what do you call it, frowning, another face, what do you call it, having some tears. These are the faces scale for children. We have color analog scale. You know, we have visual analog scale. If you search, you are going to see color analog scale is for children also from 5 to 7. It depends on the color. Start from green. When they see red, that is severe. Then the child will tell you where he is. They will now have children hostel of the children hostel of Eastern Ontario pain scale. We have CHIOPS. We use it for post-operative observational pain rating scale. We use it post-operatively when the child underwent operation and want to assess his pain level post-operatively. We use the CHIOPS. Then for adolescents, we use visual analog scale, VAS. Please, there is another scale I've forgotten the name. We use it for severely mental, what do you call it? Severe mental retardation. Children that have severe mental retardation, I've forgotten the name. We use it to assess pain in them. Then pain management. Pain management, what I want to say here is the management of pain and spasticity share some relationships. Like massage can be used to relieve pain and spasm in children. Heat therapy can be used, cryotherapy can be used, and TENS. TENS can be used for both spasticity and what do you call it, and pain. And then remember, the only modality that we use to treat pain in cancer is TENS. We don't use heating modality. We don't use, but you use what? TENS. Even if a child has TENS, we use it. For child with what do you call it? With juvenile rheumatoid arthritis, we use cryotherapy. We use TENS and we use physical range of motion exercise also. Yes. Therefore, this one in summary, you can use all these modalities that we have mentioned before in spasticity can also be applicable in other wide variety of what do you call it condition. A child with antalgic gait can also use it. We can use cryotherapy if it is acute. If it is chronic, we can use heat massage and we can use TENS. Therefore, the next is we look at systematic reviews, but majority Okay, we are welcome back again. The network is not really doing us good, but we are almost through. Then the next thing, I have said this before, that the child will also have to be assessed, most especially those that are up to 2 years and above, for any sign of withdrawal, any sign of anxiety in this guy. If there is need, we can refer them to the psychiatric unit for further assessments. They can still continue with the physiotherapy if there is elements of anxiety or depression in the child due to the condition he is having, most especially those that are managing children with sickle cell disease. Today crisis, tomorrow crisis, and we keep managing them like that. If there is need, or some of them with severe spasticity that they always show sign of suffering, therefore, if there is any element of withdrawal, we can refer them to the psychiatrist for further management. Here we have a systematic review and I was trying to tell you that when I went through the systematic reviews that relates to pain in children, uh, receiving physiotherapy, most of the researches were on post-operative or whenever there is any procedure. Then let's look at what they said. They said systematic review by Lexus et al. 2021 reported that non-nutritive sucking and rocking, holding are non-pharmacological interventions that have best supporting evidence for pain reduction during acute painful procedures, neonates and older infants. What they are saying is that when you are performing a procedure on a child, like for example, you are mobilizing, you are doing something, if the mother hold the child and the mother is rocking, they said it's one of the best non-pharmacologic treatment. Or the mother can give something. They used to put pacifier in the mouth. Go. At times the child will be sucking pacifier. Therefore, it's one of the ways, they can reduce pain in these children. In some, it's very common for our mothers when the child starts crying because of anything, they will now begin to breastfeed the child, and then the pain will go. Therefore, they are telling you that this is a non-pharmacologic, procedure. Like the doctor want to give injection, the mother can easily start rocking the child or put pacifier in the mouth or doing anything that they said it works. They said a major advantage of using non-pharmacologic intervention is the safety profile compared to pharmacologic intervention that often have associated side effects. Then they now said under systematic review by Hugh et al. Report that virtual reality education is effective in reducing children's anxiety during medical procedures. What they are saying is this one can also be applied to physiotherapy. Like a child that is coming to receive an injection, you can play him some video where some other children are just laughing as they receive injection, or they want to do dressing for him or anything. You now see the child will receive prior information on what that thing is. It's as simple, be a man, we are going to do this. Look at these children playing. And then when the child comes to receive that procedure, it will just be okay. There is no anxiety of that procedure is something new he doesn't know. That is what this guy is saying. Reporting that virtual reality education is effective in reducing children's anxiety during medical procedure. They say it can help children overcome and become familiar with the medical environment, overcome anxiety and fear, and learn about medical procedure in advance. Therefore, you can easily show him that when we go today, this is what they will just remove this thing, and this is how they do it. And then it's like trying to prepare his mind. And when somebody comes and say, I'm going to do this, after all, he has seen it. They say it's part of non-pharmacological kind of management of pain. This can enhance their cooperation during medical process and leading to more positive medical experience. This is virtual reality education. Then the other one, we have systematic review by Ostojic et al. Reported that there is strong evidence for pharmacological treatment for postoperative pain and in children and adolescents. What they are saying is whenever there is a surgical procedure, the strongest evidence is for pharmacological agents, meaning that though 10 is very important, cryotherapy is very important. If somebody has undergone surgery, the best form of treatment for him is to receive what? pharmacological agents. The next is there is moderate evidence for efficacy of intrathecal baclofen. Remember the intrathecal baclofen, the one that is being put under the skin for pain-related hypertonia. Therefore, they now say there is moderate evidence. If children have pain that relates to spasticity, they say based on their systematic review that pain relating to hypertonia, severe spasticity of the whole body, that there is moderate evidence that if a child receives intrathecal baclofen, both spasticity and pain will reduce. That is what they are saying. But they said there is limited evidence, meaning that there is no, only few, less quality studies report this. There is limited evidence for non-pharmacological pain management strategies in pediatric CP. What they are saying here is the effect of non-pharmacological interventions, actually there is limited evidence, meaning that there is need for more and more researches, most especially in physiotherapy arena, on pain-related issues. Most of the researches we conduct Okay, can you hear me? Okay, we are back. The network is still punishing us. Therefore, the last one, they said there is limited evidence for non-pharmacological pain management strategies in physiotherapy, in pediatric CP. Therefore, what we are really saying here is, it is not because many modalities that we use are not effective, but probably our researches are geared towards more of improvement in motor function. We want to improve walking, we want to improve standing, we want to improve walking, standing, running, quality of life balance. And there is less research on pain and pain-related issues in these children. Therefore, there is need for more researches on pain management in these children. Another research by Ostojic 2018b reported that distraction. What is distraction? Somebody teaching a child to take his mind away from the pain. Imagery, that is motor imagery, and pre-preparation, education. Just like the other one we said, enough education is effective in post-operative, procedural pain management in general pediatric population. Therefore, whenever there is a particular procedure, no matter how little it is, when the child is probably improved, and then if the child is being distracted as they are doing it, the mother is playing with the child, distraction. Therefore, or mental imagery, you know what mental imagery, mental practice. Okay, as they are doing it, you just feel as if, yes, you have learned that you are not going to cry, all these stuffs. Therefore, they said they are effective in post-operative pain management. Therefore, in essence, most of the researches, systematic reviews, they dwell more on operative pain management. Conclusion, we said pain in children can be physical or behavioral. Physical pain is the pain that is caused by actual tissue damage. It can be behavioral because of something that happened that changes anxiety, that brings anxiety or emotion. It can facilitate increase in pain perception. They said accurate pain assessment and adequate management is essential for children with neurological disorders because definitely pain used to provoke disability. It presents with unwanted posture. It can also prevent a child from walking and playing with other children. We said it prevents participation. It can lead to absenteeism from school and all other negatives that has to do with pain. We said though physiotherapists can manage pain in pediatric population, but disciplinary approach proves and may provide relief, what do you call it, the best relief for the child. What we mean here is we have to, as a matter of what do you call it, concern, or manage pain. If the pain will not go, either refer the patient back to the doctor for adequate for further management. We can also refer to the psychiatrist if the child is more than 2 years and probably has exhibited some behavioral changes that may warrant psychiatric what do you call it, evaluation. We said thank you for listening, and with this we come to the end of today's lecture. We talk about initially we talk about spasticity and management. We talk about dystonia and approaches, and then now we talk about little. We said that we are not going to discuss what they call extensively on the pain. It's because of the spasticity and dystonia. But all of them can affect the child ability to walk, and they can affect his gait. Thank you very much for listening.
Thank you very much, sir.
Okay, during my last week lecture, there is one of the participants that has a question. I think she sent the question to Ray. If she is available, she can ask the question again so that we discuss. I was sent the question, but actually I didn't have enough time to sit down. Therefore, if she can voice out again so that we discuss the case scope. Hmm? Okay.
Erika.
Okay, Erika. Okay. Dr. Erika, I'm together with you now. Are you with me, Dr. Erika? Okay, Hafiz, please can you read the question so that we discuss? Yes, it is in a chat. I forgot actually what she said so that we can discuss it. Okay, he said he lost the previous chat. Then definitely I'm going to answer it and send voice message to Dr. Erika. Then concerning, I think it's okay, but then concerning today's lecture, please comment and contributions. Dr. Hafiz, are you hearing me?
Questions, comments, and contributions.
Okay, I want to thank you for listening, and I want to appreciate you for staying with me up to the end because we had serious what do you call it, network issues. For Dr. Erika, I'm going to send her voice message. If I read this thing back again, they send it to my WhatsApp. I'm going to read back and I'm going to give her my input. And I thank you very much for listening. Oh, is it?
Sorry,
Okay.
sir. I didn't know. I heard.
Okay, Dr. Erika, how are you?
Yes, sir. I heard my name now. Sorry, sir.
Okay,
Network
yes, you
challenge, sir.
asked. Yes, when you asked your question, actually, I was also busy throughout the week. I said when I come, we are going to discuss it.
Okay, sir. Okay, sir. Okay,
You
should I
said
repeat
there
the
is
question?
a child with injection palsy.
Yes, sir. Yes, sir. Actually, there are two pediatrics with injection
Okay.
palsy.
Yes.
One of them, as in the one is a male child,
Yes.
3 years, with foot drop, with
Yes.
big toe plantar flexion,
Yes.
like big toe. Okay.
Yes.
And
Yes.
hyperflexion of the knee.
But actually, the knee joint is having full range of motion.
Yes, full range of motion.
Yes.
But just
Only
that,
that when he is walking, there is a high stepping.
yes, high step-aid gait.
Yes.
It was the child presented with atrophy then, but now the atrophy is no longer there. But our challenge is that the child still walk in that high step-aid gaits with the big toe flexion.
Yes.
And this
Actually, I
actually
know. Yes, I'm with you.
for past 4 months.
But
And
actually,
that
what about the hip? Does the hip have full range of motion?
full range of motion at the hip.
Yes.
So my concern was that is it that I don't know, is it the level of is it the severity
Yeah.
of the session that leads to that? Because the parents were
Yes.
they were committed to their treatment and they do their home program. The child also obey commands and they do their home exercises and do stimulate. So I was confused at the
And
point
then
that
yes, that particular high stepping has become behavioral.
and because if the child forgot himself, he do work normal. But when he remember himself, I will still sit down gate again. I was like,
Yes, you
is it
see,
that he's
that is
now
part of the
as I'm
hello.
listening, sir.
Okay, the net. Okay, what we are
Sorry.
saying here is that is part of what the children at times we that manage children we used to face. At times the impairment or the weakness will go, but behaviorally they have learned to work in a particular pattern.
Okay,
Breaking the pattern will now become another issue. Remember what I said for children working on toes. At
yes,
times
sir.
you will manage what do you call it, the spasticity, everything. But if care is not taken, if the child is not called to order, you have to now bring the child very close, inform the parents that okay, he should now put it consciously that he should be walking without raising that particular leg. But one thing is that is he fitted with anti-foot drop device? It
Yes,
can
yes.
be hinge AFO, and the
He's using
anti-foot
Apple,
drop is working.
sir.
And the foot drop is working. There is no foot drop in swing face.
No. Once he's with the AFO, he works normal. But once you
Yes.
remove the AFO, you see the bad.
Therefore, one thing
high
is that don't remove the AFO.
Okay,
The
they
most
should be
important
wearing.
thing, yes, usually look for what we call posterior leaf spring. Posterior leaf spring. Go on the internet. You are going to see posterior leaf spring. Posterior leaf, LEAF, leaf spring.
Okay.
They should insert it inside his shoes. He should just be walking. Let him be wearing canvas. That thing is going to hold the leg. In swing face is going to maintain what do you call it, dorsiflexion. Seeing that thing
Okay, sir.
outside is what is telling parent that up till now the child is not doing well. He's still wearing anti-foot drop device. If you put posterior leaf spring inside the shoe, it's going to maintain dorsiflexion. And another, we know one good exercise for these guys is
Okay, sir.
stair climbing.
He sometimes even do
Majority
20
of them,
years.
if you encourage stair climb, he used to do it at home, Ko?
Of course, sir.
Yes, stair climbing is a very good exercise for them, initiated usually with the affected leg, going up, coming down, going up, coming down. Then we can now put something. Usually, behaviorally, if he's raising the leg too much, we now tell him, you observe, you are raising your leg. Why are you raising your leg? Then he must learn to subconsciously or consciously to walk without raising his leg. Since we apply this, he has been walking that way, and it has been already, he has become used to it.
Yes, sir.
Yes.
Sir.
It's the
That's
same
what
thing
I
with
found.
toe. You can manage toe walking and you are done, oh, everything is done, and the child will now subconsciously start to walk on toes. Then both the therapist and the mother will now have to now sit him down. Then consciously he has to learn that he has to walk without raising the leg.
Okay, sir. But just that the
We
age
have
is
done our
overwhelmed.
own. That is why we said psychologically, the physiotherapist has to be physical therapist and also a psychologist working with children.
Okay, sir. Okay, sir. Okay, sir.
What will
Thank
you do to a
sir.
child that immediately he comes to the clinic, he saw you, he start crying? That
Yes,
means no physiotherapy. Yes, most especially some small children, immediately they see your face when you come to the clinic, they start crying.
that is their normal
Therefore,
character.
therefore, what is there? If they develop that thing, they will never get receive physiotherapy from you. The most important thing is, okay, we now begin to see him in a separate place other than that particular clinic. The same you. Then gradually, when the child become used to you having like 2 or 3 treatment sessions, you will be the now one that will now bring him to the clinic, to the physiotherapy area, not to the mother. Then that is all.
Okay, sir. Okay, sir. Okay, I appreciate that. Sir, remember number 2 question, because I told you the two.
But actually, walking, even after treatment, walking with excessive high stepping is behavioral. It has to be stopped.
Okay, sir. Okay, sir. Okay, sir. Okay, I now understand. Okay, sir. So, remaining the second question, sir. Hello, sir. Hello. Network don't come now. Hello, sir.
Hello, sir.
Hello, sir. Can you hear me, sir?
Yes, I'm with you. Yes.
Okay, sir. The second question, that the child of AE and Ethmos that has foot drop and also a version from the hip. So the foot drop
Okay.
have corrected, but the version from the challenge. Although the child is wearing AFO, but he's dragging the leg on the floor. He can't even use the AFO. Talk more of the canvas.
Okay, it's dragging the leg.
Dragging, they can't even lift the leg up. And he's
Okay, no, one thing
serious
is that, does he have active knee flexion?
Yes, she has.
Active knee flexion.
Yes, sir.
And she's not, yes. And then, like, for example, the dorsiflexors. What is the strength of the dorsiflexors? 1, 2, 3 of the leg.
2.
2.
Yes, sir.
Oh, if the dorsiflexors are actually 2, definitely this guy will continue to drag the foot because the foot cannot what do you call it what do you call the what do you call it, the tibialis anterior muscles cannot clear the foot off ground. Therefore, the child would have to, the first is that the child will have to continue wearing anti-foot drop device to raise the leg. And another thing is, the footwear, it depends. Is the child does not supposed to wear slippers. The footwear that is very comfortable, they shouldn't wear slippers, because managing slippers and the foot that is weak is another thing. The anti-foot drop device should be placed in a canvas where the child will be able to control the leg. And then the next thing is, definitely you have to have a training session. There must be obstacles on the road that the child will be using to be raising the leg up. The only thing is that you said the child have external rotation of the hip. Is that also?
Yes, sir. The eversion is from the hip, not
Yes,
just the
if the child has external rotation of the hip. Okay, is it of the hip? Is it eversion of the foot or the hip?
The eversion
Hello.
started from the hip down to the foot. So it's not just
Okay,
only the, not just the,
inversion.
yes,
Is
eversion.
it inversion inward? Okay, inversion inward.
Outward, eversion, outward.
Hello.
Hello, sir. Can you hear me?
Yeah, I can hear you now. Okay, we said inversion inward.
No, EVER. Eversion.
Hello, can you hear me? Yes, I can hear you. The thing is breaking, but I can hear you.
Sorry, sir. It's network challenge.
Hello.
Please, sir. It's EVERSION.
Okay, eversion.
Yes.
Okay,
Yes, sir.
what will happen is, can the child, what do you call it, obey command?
No, he doesn't.
Yep.
She doesn't. Hello, sir. She doesn't.
That is where the problem is.
Even at home, she doesn't. All the home program I've given them so far, the
You know,
mother
it's
said that
part of the questions that we answered the other time.
yes, sir.
It's part of the question that we answered the other time. Therefore, we do gentle passive inversion so that the limb become the limb straightens. We do gentle inversion exercise usually in this case where the child cannot do for himself and does not respond to command. You have to do a passive rotation of the hip to normal, like 100 times. You ask them to do it morning, afternoon, evening. 10 you do 10 times rest, 10 times rest, up to even I found this. I was taught this by my type professor. Like,
yes,
if you want to do passive movement that will be useful to the child, when you do 10 times passive movement, it will not work. When we are managing a child with Erb's palsy, she will tell me for each group of muscle, give 100 repetition of passive movement. That is what is going to help the muscle. Therefore, for biceps, I do 100 repetitions, do 10 rest, 10 rest. If I do 50, I allow the child to rest. I do another 50, then I'll come to wrist extensors. Do 10, 10, 10. If I do 10 rest, 10 rest, 10 rest. Because one active movement will do what 50 passive movement will not do. Therefore, for this child, since it is on eversion, you have to do eversion, then 100 times, 50, 10, 20, 30, 40, 50, the parent should do. Then another issue is, the other time we discussed this, the issue of external, internal rotation, the child, that bridging exercise can also help if the child can also obey command. If the child cannot obey command, you can also do assisted bridging for the child. Then another issue is, we hold the two limbs in bridging, then the one that is less strong, if you put the child in the in the crook lying position, that is almost like the bridging with the two legs bent. You need one of the two knees will be high, then the leg that is weak is likely going to fall off. Encourage the child to bring the leg backward. Some of these things can do help the child, but if the child, the worst period in pediatric training is when you want to achieve something and the child does not respond.
Yes, it baffled me.
Therefore, passive movement can do, your breathing can do. Then in that particular position of in the crook lying position, the adduction can also do. Try also in that position to ensure that the normal alignment is maintained through passive movement. A lot of range of motion passive movement. The parents can also be doing that up to the time when the child will not be able to follow up. There is little we can do when the child does not obey command.
That is my concern. That's my concern, because the mother will also comply
can
with
do more.
Mother is recovering, but her child is not recovering.
Yes. Then you should tell them, okay, you do your part. They should also be doing their part up to the time when the child will start responding.
Yes, sir. Okay, sir.
Because you cannot bring. Yes, I'm with you.
Okay, sir. I'm hearing, sir.
Okay.
So I'm listening.
Hello.
Hello, sir. I'm listening.
Okay. Therefore, there is something, you see, no matter how little, when you ask somebody to do something and he is able to do it, it's just for you to consolidate on the gain that you have. When he cannot do it, then you have no option than to do it passively. You continue doing it until when one day he will respond and start following your command.
Okay, sir. Okay, sir. Because now, at the point, I was even considering if you can do serial casting.
Yes, one thing with the serial casting is, you want to do serial casting, is it for, you said there is full range of motion in the hip and the knee joint. The only thing is that there is eversion. Come?
Yes, sir. Yes, sir.
Where are you going to do the serial casting?
As in to achieve eversion, to achieve inversion.
Okay, yes, you can do it, but remember, serial casting maintain a limb in particular posture for some time. And we have seen that we cannot maintain a limb for more than a week. And then, if the muscles are very weak, they are likely going to become weaker.
Yes, sir. That
We do
is
serial casting for very spastic muscles that, and you remember we said something that when you are applying serial casting for spastic muscle, where we have only the agonists.
okay.
Hello, Dr. Erika.
Hello? Yes, sir. I
Yes,
can hear you, sir.
yes, therefore, where you have, remember what I said, where you have, like, for example, you are doing it on for the on elbow, on the knee joint, where you have the hamstrings are the ones that are giving tough time because of severe spasticity and the leg is flexing. Then, if it stays for some time, the hamstrings are going to become okay because you stretch them, but the quadriceps that are not working are likely going to become weak. Therefore, we should also think of the hip muscles. Come, if they are not very strong, despite the fact that we are very enthusiastic and we want to improve on the posture of this leg, we should also be very careful if the muscles are weak. But if the muscles are strong, no problem. It's just behaviorally that the child turn the leg outward, evert the leg outward, then we can easily do it. Assess for the strength of the muscles, or you apply it weekly, and then you do a lot of exercise, then you reapply it again. But assess the strength of the muscles such that weakness will not set in. You know, serial casting does not allow what do you call it, for passive for active exercises.
Yes, sir.
Okay.
Okay, but if we review, if we cast and review every week and do exercises, so it will give us a positive result, sir.
Yes, try if there is enough muscle strength, more especially around the hip area, you perform, you now bring the leg to normal alignment. At least after a week, in a week, you now assess. If the child is doing well, then you continue with your exercise for a week, then you now apply it again, then probably you see what you can achieve.
Okay, sir. Okay, sir. Okay, sir. Okay, sir. Highly appreciated, sir.
Thank you so very much, sir.
I wish you all
Thank
the
you.
best.
Thank you, sir. God bless you, sir. Thank you, sir. I really
Okay,
appreciate
and
it.
okay, thank you.
I'll keep you posted, sir.
Okay, so thank you very much. I'm going to take a leave so that it's almost time for another prayer. Thank you for
Okay.
listening. We keep rubbing minds, coming up with topics that will enrich us in our clinical practice. Thank you very much.
Thank you, sir. Thank you,
Thank
sir.
you, sir.
Thank you, sir.